hospital records, let's say over the past 10 years, 20 years, and feed it to these models. They can build rigorous statistical models for you that could predict the occurrence of these diseases with a very high degree of certainty. Now, let's take the case of sepsis. A patient comes in. Traditionally, we have to wait for about 5 days to obtain cultures, which can contribute to the demise of the patient. And also, people have financial barriers. They can't afford the cultures, and they end up dying as a result of this. But if we have a well-built database with, let's say, about 10,000 cases of this kind of sepsis over there, we can make a very accurate prediction as to which organism and which antibiotic will most likely work then. Then we initiate our empirical treatment based on that choice. So AI models are very useful to us in any setting we find ourselves, and we must make use of this. Now, let's look at the smartwatch. The smartwatch, a very helpful tool in this day and age, can measure blood sugar, blood pressure, non-invasively. I must say, with sugar and pressure, FDA is really yet to make put a firm stance on that. For blood pressure, I think recently, just a few months ago, they've approved for the use of a band, a wristband, basically in the form of this watch, and therefore our subsequent watches that are going to come, the Samsung 9 and things, will all have these features embedded. It can measure body temperature, can measure pulse, oxygen saturation, and future studies are ongoing to get it to measure hemoglobin levels non-invasively. It can monitor or measure calories and stress levels. All this information are very important for us as clinicians, as medical practitioners, and they help in managing patients and improve care holistically. These are some of the underlying technologies behind these things. So we can see over here the child, the mother, the old man, just to illustrate that all spectrum. It can be very useful in all facets of life. Children, monitoring growth, monitoring anemia. The pregnant woman we've talked about, BP, sugar, anemia, all this sepsis, they can be picked up early if people get wearables, if people use AI-embedded applications. Diabetes can now be controlled digitally. We can see on that arm, the arm of the patient on the extreme left, that round white thing there, that's the continuous monitor. These are readily available. Currently, there are a few in town in Accra over here, and we can get them for diabetics. We also have digital pancreas or bionic pancreases, which can deliver insulin at a very precise rate, and it's very useful, particularly for type 1 diabetics. Let's see. Now, Elon Musk, hero, now has devised the brain chips. So the story of strokes and brain injuries and things is gradually coming to an end. Very soon, even blindness can be curable with artificial intelligence. We just need to slot in a chip somewhere in your occipital brain, the visual area, connected to some devices that can pick up signals around, and then you can see, even if you don't have eyes. Brains can now communicate with machines. People play games. I think they've done trial for about 10 patients now. They can all move software with the use of cases. Right, so AI can be applied everywhere. In our ICUs, in our emergency settings, we use data all across. AI models can make predictions, can help us to control air pollution, accidents, and all that, discover drugs and vaccines. So it would significantly reduce the time we spend in clinical trials and all that. Clinical decision support as private medical practitioners. We can leverage the ChatGPT in our consulting rooms, make references here and there. We can make use of telemedicine and AI to seek services that are not available in our hospitals. Speech, voice, sound can all be analyzed with AI. So you are listening to a murmur or a heart sound, you are not sure, just record it, upload it to your ChatGPT. It's going to analyze the graphical waveform of it and give you a descriptive diagnosis of, or the description of what you are hearing, whether it's a pansystolic murmur or an S1 or S2, whatever it is, no ambiguities at all. The graph is there, we can see whatever is going on. Disease can be modeled, high risk groups can be identified and interventions made. I'll not go too much into robotics, another field of AI application. We'll tackle that in the afternoon. And there are a lot of wonderful things going on there too. Now, lastly, virtual reality, augmented reality. These are also technologies we can harness in treating psychiatric disorders, neuronal disorders, things like stress, anxiety, depression, phobias. A patient suffering from a phobia, we could just give the person this headset, simulate the experience of maybe ascending to a tower 200 floors high. And then when the patient does that a few times, the phobia disappears. So we can use it to treat phobia, anxiety, depression. There are various softwares we can use to engage the patients to treat this. So we can inculcate augmented reality. There are AR, VR headsets readily available in town, even around us here. We can get some in our clinics and start using these. Our surgeons can use AR, VR in their treatments, from surgical navigation to anatomy, descriptions, and all that. It really enhances surgery. There's an example of a patient receiving psychotherapy using the VR headset. So the psychologist guides the patient. He sees a certain environment. The environment might be calming or relaxing or soothing, and it can help in the treatment. Stroke care can be greatly enhanced with AR and VR. We can immerse our stroke patients in a VR world, and the act of the immersion alone is known to stimulate neuroplasticity and development of neurons, and therefore can aid in recuperation from diseases like strokes. Now, a few contraindications. VR therapy is not for everyone. There are situations in which we need to do away situations that are precluded for VR use. So it's important that you see some digital practitioner to examine the situation and give you the guidelines. We shall talk more about VR in the afternoon in addition to robotics. So I'll end here so people can ask questions. Thank you all. Good morning.
Thank you, Doc. Please hold on to your questions after the second presentation. Then, also wanted to ask some questions now. All right, okay. All right, okay. I hear some people are online, so if you have any questions, you can bring them to book now for Dr. Kwashi. For Dr. Akwa. 10 minutes.
Can you be checking on the Zoom to see if there are any questions in the chat? Doc, beyond the current diagnostic imaging, and when I was writing this question, I didn't know it had gone so far. Do you see any promising but untapped areas where we can use this AI, and are there any ethical dilemmas we might have to navigate in the use of this AI?
Yes, exactly. There are a number of wonderful things AI can do for healthcare. First of all, we are going to discover the cures to a lot of diseases very, very soon. We are going to discover a lot of drugs for potential treatment of diseases very soon because of something we call generative AI. It's able to actually churn data around and extract insights that the human eye cannot see, and just bring about new things that don't exist. Also, it's going to augment our work now. So a general practitioner seated somewhere can access a cardiologist, a radiologist, a neurologist, virtually all the specialties through ChatGPT. Any specialty you want to access, you can get that, and that can help in scaling up remote care. So AI is going to do a lot of wondrous things in addition to the diagnosis we've talked about. About the ethical dilemmas, AI can make grave mistakes, it can make hallucinations, it can give false statements, all from computational discrepancies. So there is the need for us to understand how AI works. There's a need for us to learn how to go about hallucinations, to be able to find ways to accurately verify facts from AI so that we are not being misled, so that we can harness the productive side of AI while limiting the safety concerns associated with its use. Thank you, ma'am.
Yes. What is Dr. Jose? There's a question.
Okay, so good morning, everybody, and thank you so much for the first presentation. I have two issues. One you just mentioned briefly, so let me tackle that in terms of ethics. So when AI makes a hallucination, a mistake, who takes responsibility for that? Then secondly, with the few things what AI has the potential of doing in the medical practice, what do you foresee to be the impact of AI on teaching and learning in our training institutions? Thank you very much.
Thank you, sir.
Another question.
Good morning.
Go on.
Doc, you talk about production of vaccines. Now, I think yesterday, Donald Trump says he's taking away 500 million from the production of vaccines. How soon is AI going to give us the vaccines we need?
Okay, thank you. I'll begin with the first person who asked the question. So, sir, please, in response to your first question, you asked who do we hold accountable for AI's faults. So, ethical, legal frameworks have to be developed globally. In the developed world, these are somewhat well spelt, but stakeholders involved will include the manufacturer, the user, or in our case, the healthcare practitioner and the patient. And it's a matter of responsibility for the physician, just as maybe, let's say, for example, using the analogy, if you are a driver, you have to be licensed and certified after having received training to use a vehicle. So similarly, for you to use AI in medical practice, you should have undergone some training and be certified that you understand AI, you understand its benefits, risks, and limitations, and you know how to use it. That would have meant we would have fulfilled, let's say, due diligence on your part. Now, there are instances where it's a pure technical issue. Maybe it's from the manufacturer. Perhaps there were limitations in the data sets that were used to train the algorithm, or it is a known bias of that particular algorithm, or maybe due to internet fluctuations, current fluctuations, perhaps some tranche of data was missed during the processing pipeline. These ones, the manufacturer will have to bear. So at the end of the day, the problem with AI use is borne by both the doctor or the practitioner using it, and then the manufacturer as well. So legal frameworks are being developed globally. I believe soon in a part of the world that will be done. But like I said, at least should you fall foul as Dr. A, having used AI and the patient, let's say, suffered or died, one of the questions the magistrate will want to know is, do you know how to use AI? So then you should make sure you know how to use it before you do such things. He asked a second question which bordered on teaching and training of people to use AI, or general training. Yes, so currently there is a course, digital medicine, which includes AI. I happen to handle it at the undergraduate level at the Family Health Medical School and the Accra College of Medicine. Efforts are being made to insert it into University of Ghana's curricula for undergraduates very soon. And recently to the Ghana College of Physicians and Surgeons have given the green light for this program to be rolled out for the postgraduates, the residents and the specialists. So very soon, medical doctors will all be trained and certified in AI and digital technology in practice. But then before, while these things are getting on, or before these things come up, it will be good for us as individuals, as a matter of responsibility, to try and learn on our own. There are a lot of free softwares and courses and applications on the internet, YouTube, and various platforms where you can freely learn. I'm coming up with a course next month, which I've projected up there to an online course, basically 3 weeks, to give people some foundation in AI. You could enroll, you could dial the number and register, and you have some knowledge on it. You could also read about AI, basically just be knowledgeable about it so that you can be in a position to use it well. To our second speaker, please, your question was about the vaccines that are being developed. So, yes, please. The vaccines will come out very, very soon. In fact, I think in less than a year, we should have these vaccines. These things, we are looking at days and weeks with the use of our GPUs and our large language models, our generative AI models. We can actually generate drug targets, vaccine targets. We can synthesize them, even those that don't exist. And we can search through them in seconds using very powerful computers to identify potential vaccines that we can develop. So, and that's I think that takes the chunk of the time in the vaccine development chain. When we identify the candidate molecules, then we just have to follow the clinical trials, the ethical stages 1, 2, 3, 4, and then we get it. So this has been greatly shortened, and I believe in the next year we should see these vaccines you are talking about.
Okay. From another AI guru, I will allow one question or contribution, but yes, very short, because yes, it's time for you to come up.
Okay. So it's just a quick contribution. Just a reminder that AI research started long ago. They've been trying to do it since the 1950s. But we talk about ChatGPT. It just came out. It was released on 30th November 2022. We are now in 2025. So you can see the timeline. It wasn't released long ago, and so there's a lot of things going on. With the use of AI, I thought I was going to use my computer when I was going to present, because I had some examples to show you, but I'll just make a statement about it. When you ask AI a question, there's something we call prompt engineering. You have to ask it a question with a background. Like, if I ask a question, what is sepsis? It assumes I'm a layman. It just gives me some basic information about sepsis. If I ask AI and I tell AI that I'm a medical doctor, what is sepsis? It will now search deeper and give me information that, as a doctor, I will understand. And I can ask deeper questions. And it will answer because it knows I'm a doctor, so it will go deeper. At the same time, if I ask it as a doctor, it may even give me references. But if you just ask a cursory question without giving it a background of who you are, where you are from, and stuff like that, it just gleams through the internet and gives you some basic, sometimes it's even chaff. So the use of AI, although it's there, you have to do what we call prompt engineering. When you're asking a question, you try to give it some background of who you are, where you are coming from, or why you are asking the question. Then it goes deeper to search. So you find out that sometimes you ask a question, it's searching around the internet. It takes longer to answer a deeper question than if you just ask a general question. And then I just wanted to give this background as well.
Thank you, Dr. Bawumia.
Thank you. I would want to ask the speaker whether there have been real known downsides of AI that have been put in the background. And also, since it's something you can get online, how is it going to, what's being put in place to protect the general public from quacks who would get information and start to present themselves as caregivers and take advantage of the general public? Thank you.
Thank you, sir. So there are real issues with the use of AI. These include things like bias in training data. So, for example, ChatGPT was trained with data mainly from the West. So its decisions will be shifted more towards diseases and conditions prevailing over there and biased towards us. So there is a need for us to locally develop our AI models. And this will require us to generate our own training data sets. So we need to set up data centers, buy giant computers, and then train our models and develop our own local GPTs over here, and they will mitigate the issue of bias. Other than that, we'll be making biased decisions using some of these models. But they are somewhat okay at the moment, though. There's also the problem of transparency and explainability. So doctors in particular find it difficult to hold on to AI because they can't explain how it works. You ask a question, fever, chills, this, it tells you it's malaria, but you are not really certain how it arrived at that answer. So there is a need for more training to make AI explainable to people. And there's an active area of ongoing research, what we call explainable AI, so that the AI doesn't just give you the answer, but it tells you stepwise how it arrived at this. These algorithms work, but I must say they are very, very sophisticated, and their modus operandi is for some, the modus operandi for some of them are basically incomprehensible. It's not that they don't work, but it's difficult for the human mind to understand them into detail. The third one, about notable cases. There are lots of cases globally. There are lots of instances where AI has picked up cancers years before the human eye, and then this has saved lives. There are instances where AI has made diagnosis that the clinicians missed, and it helped the patients in the long run. There are instances too that it has misled clinicians. We can go on the net. There are there's news all over globally. There are instances where patients have used AI after seeing their doctors and seen different diagnoses which saved their lives. Maybe the doctor diagnosed condition A, but the AI diagnosed condition B, and the patient had a second opinion from the AI, stood by it, and was saved. There are instances like that. There are instances too that AI has misled people in that regard. There are lots of them on the internet. We can readily verify this. So please, your very last bit of the question. I think you... The quacks.
Yes.
Yes. So again, it comes with training, licensure, and validation. So we need laws in the country to train doctors to use AI, to certify them as an AI certified practitioner, so that if the patient visits the doctor, he knows my doctor is AI certified, so that a quack cannot do that for the patient. And then also we need validators. We need doctors who are well trained in computer science to validate the outputs of AI. AI reads a patient's notes and says he has malaria. Somebody must sit down and assure the world that AI used the right algorithms, it used the right training data, it made the right mathematical prediction or conclusion as to that. So that person should be well trained in medicine, should be well trained in computer science to pick that role to assure the world that the information coming is true. If these mechanisms and systems are in place, then there'll be no room for quacks to mislead the world. But I believe gradually our lawmakers will get us there.
Okay, thank you, Dr.
George
Aqua.
Thank you, sir.
Now you invite the second presenter, Dr. Hamza
Baumia, not the presidential candidate. He is going to talk to us about innovative medical devices, diagnostic tools, and telemedicine, their impact on healthcare delivery. Dr. Baumia, you are welcome.
Thank you. I think I'll use this one. Okay. My slides are not up yet, so. Okay, so whilst we wait for the slides, I just told you about the fact that ChatGPT came not long ago. So I'm sure our legal people are also struggling to catch up with some of the medical legal issues that we are thinking about. And we are hoping that some of our doctors who are in the legal field will also jump into the AI field so that they can serve as consultants or knowledgeable people to advise governments in this area. I think my slides are up now. So I'm going to talk about innovative medical devices and diagnostic tools, which is on its own a lecture, and then telemedicine, which is another lecture on its own, and then try to give the impact of these on health delivery. It's quite a packed lecture. I'll try to finish on time so that... Okay, so my name is Dr. Hamza Baumia. I'm a medical doctor. I'm also a full-stack web developer. That means I'm a computer programmer. I program software. And I'm a Google-certified data analyst. And I hold a master's degree in health informatics. So I suppose I'm well qualified to talk about this topic. Let me see. Do I have my... Which one is... Left and right, right? Okay. Oh, okay. It puts it off. Okay. Okay. Thank you, Dr. Akwa. Okay, so my objective is to showcase the innovative medical technologies and how they are transforming clinical workflows and diagnostics and also patient care delivery. I want to ask a simple question. How many of you are currently using telemedicine? If anybody is using telemedicine here. Okay, Focus is using it. And then how many of you are using the wearable devices like the smart watches and the rest? Okay, so maybe we are not using it yet. Maybe we have people who doubt it. The outline of my presentation, innovative medical devices, we'll look at the diagnostics, telemedicine, benefits of telemedicine, best practices in telemedicine, a future of telemedicine, and then we'll conclude. So with the innovative medical devices, I'll just highlight some of them. We have the wearable devices and biosensors. Examples include the Apple Watch ECG, which you just wear it, and it tries to get the ECG readings, and you can see that on your phone. And some patients can forward it to their doctors and stuff. We have the continuous glucose monitor, and then we have smart inhalers. These ones, the smart inhalers, they actually detect and count the number of times your patient is using the inhaler, and also the dosing, which can be sent to the doctor to know whether their patients are using it or not, and even the frequency. So if you have a patient that's using it for maybe once a day, and then all of a sudden you realize that the frequency is going up, you may want to call the patient to examine the patient or so, something like that. So these smart devices help mostly in the management of chronic diseases, which are very good, and then for remote monitoring. This is a picture of the smart the smartwatch with the ECG. The Apple one is the one on. Okay, so for you to be on your right, and the other one is the continuous glucose monitor. It's actually like I had a video on it, but since I don't have my laptop with me, it's actually as you can see, circular, but there's a needle, a small needle in it that you actually, when you put it as a patch, it goes into the skin to take the reading. So it's not just a pad there. There's a needle in it that takes the reading. So it takes the reading, depending on how you set it up. Some people, every 15 minutes or so, then it sends the reading to your phone. Okay, so there are also implantable smart devices like the leadless pacemaker, the smart orthopedic implants as well. I'm sure Focus will be happy about that. The orthopedic implants, just like when they do a knee replacement or something, they have these implants, the smart ones, able to detect the wear and tear of the joint, so that they're able to track and know when to do any intervention, rather than just leave you to go on without any detection. That's it. So this a picture of the leadless pacemaker. You can see how small it is in there on the picture there. It's actually, if you look at it, it's actually like a coin. The length of it is about a coin, and they pass it through a catheter and into the heart. Unfortunately, I think currently it's just able to work in one chamber at a time. If you compare it to the traditional one with all those wires going through your heart, this is a little better. And these are smart as well. They give information whilst you are to the provider. AI-powered devices, we have portable ultrasound scans with AI interpretation, just like the Butterfly IQ, the smart stethoscopes. These stethoscopes can pick up the sound, and they use the sound waves to interpret what's going on, and they can also detect murmurs and etc. One thing I forgot to mention is AI is very good at text, reading text and stuff like that. It's also very good at images. It looks at images, it's able to look at patterns in images and stuff. And it's good at audio as well. So when you have, if you have ever looked at any audio on your computer screen, you see it's just a pattern of waves. AI is able to learn those patterns very well. And this is what we do as doctors. We are always writing text. We are always looking at images, X-rays, this, blah, blah, blah. So what AI is good at is what we mostly do as doctors. So we can't run away from AI. If AI is getting good at something that we mostly do as doctors, we might as well get involved, get to know it better, and know how to use it to help our work. Okay. So these tools I've just mentioned, picking up these data here and there, means people are going to be wearing a lot of smart watches and smart devices, and we will be flooded with a lot of data. Already our brains are occupied with a lot of things. Your patients coming with a lot of data and stuff. If you have AI to help, AI can analyze all this data and give you patterns. It helps to save time. I thought I came with I was going to use my laptop. There are now softwares like Google has what they call the Google keyboard. It's Gboard. I don't know if anybody has used Gboard here. It's on the Android store. It's free. You can download Gboard and just use it on your phone. What does it do? It helps you, when you speak, it types for you. So next time you are sitting in your consulting room and you are taking clinical notes on your computer or whatever software you are using, if you are lazy and you don't want to type, or you are doing this, your typing is not good, you can just download. I was going to show an example of it because I had it on my laptop. You just speak and it just starts typing. And it's using AI, actually, online. So as you speak, it has context, it has everything, it knows what you are talking about. It just writes everything. Actually, you can even just read a whole referral note and just send it out to somebody. You are done. Okay. The diagnostic images, as I said, AI is good in imaging, so radiography, pathology will have they have a chance to use it as well. It's highly sensitive, highly specific. It can diagnose cancers, like by looking at mammograms, can diagnose cancers ahead of time, look at chest x-rays, interpret chest x-rays, tell you whether it's a pneumonia, TB, etc., like that. Then there are also portable care, point-of-care diagnostic tools, like the portable PCR machines, which are coming up. So very soon, last time, during the COVID, people had to take sample, take it all the way to Noguchi, blah, 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 waste time. Now they are developing portable PCR machines, so you can just take a sample, put it in, and get your report. And then there's also lab-on-chip devices. These are miniature systems that are they integrate multiple laboratory functions into a chip. So next time you take a urine sample or a blood sample, you can just use your lab on a chip. It can tell you the potassium levels, whatever, your BU creatinine, all that quickly. So there are more things coming up with the innovative medical devices. There are also clinical decision support tools like IBM Watson, mainly for the oncologists anyway. And then UpToDate. I don't know whether any of you use UpToDate. I know some specialists who always quote UpToDate sometimes. It's just like a medical, just like the way we have Medscape and all that, but they added AI to it. So you read, you can ask questions. It uses medical information from all the research that's available to give you good answers. That's UpToDate there. So it can do, it can help us with information from our EMRs, that's the electronic medical systems that we are using. You can predict certain things that, especially if you are in a particular district and they have all the patients' data from your district, AI can just go through and predict certain diseases or something, some trends that are going on that each of us would not notice in our consulting rooms. Okay, so I have a question. Do you think AI will replace doctors? Anybody? Pardon me? Cardiology. Interesting. Okay, so we are the radiologists. Oh, okay, because you can view a lot of images and, well, maybe, but not really. The point is, technology is not replacing physicians, but it's in to augment our capabilities. So it's a human-AI collaboration that's going to end up. It's going to end up that it's a human-AI collaboration. For me, for instance, as I said, I'm a software developer. I program a lot. And in that area, I use AI. I use AI to augment my work. I code, but when I have things that are simple and I want AI to code for me, I leave the basic mundane ones for AI to code. It makes mistakes. So you end up having to read through the code and identify that, no, this one, there's an error here. And you can ask it. You ask it, it goes back to correct itself. And when you point out a mistake, well, the way they've set it up, it will tell you, sorry, let me go back and, that kind of thing. Anyway, but it's the same thing with us in the medical field. So you cannot, I would say, we can't say we are going to leave everything to AI. No. You need the expert. The truth is, you need the expert knowledge to be able to use AI productively. Because when you check on something and from your expert knowledge, what AI is telling you, you know that maybe there's something wrong with what AI is telling you. You can probe further. But if you are just a layman, AI gives you some chaff. Well, that's what you don't know anything deeper. So you just take it on the surface, distance. So something far. So we have words like telescope, looking at something over a distance, telegraph, sending messages over a distance, telephone, television, the broadcasting station. is broadcasting over a distance. So when we come to telemedicine, it's just simple. You are doing medicine over a distance. That's all. Have you ever sent a prescription to a friend on your phone? I'm sure most of us have done that. That is telemedicine. So we've been practicing telemedicine long before they started this AI thing and all that. And telemedicine has been there already. We have the same way when somebody calls you, doc, my daughter is sick, what should I do? And then you just talk to them on the phone. It's all telemedicine. But the real definition is providing clinical services over a distance. That's telemedicine. Then there's another term they call telehealth. When you go beyond the clinical services and you are providing education, training, and all that, that is telehealth. So all the online CPDs we've been doing, it's just telehealth we've been doing. Okay, so myself, I'm into telemedicine. Okay, so there were two problems I wanted to solve when I started telemedicine. The first one was I was having patients calling me every time here and there. You send a prescription here, you send a prescription there. It gets to a point you can't even track your patients. The patient numbers have become so many. The next time somebody calls you, you're like, is this the one with the asthma or is this the one? You are confused. So I decided to build something that I use myself when a patient calls me. It's just on my phone. I just enter the details, whatever prescriptions I send them. I send it so that I keep track of it. Next time they call me and, doc, last time the medicine you sent to me, I can just look at it and check. So that's how I did it. And then also I wanted the reward. So my software that I have, if I send a prescription to you, you cannot open the prescription. You have to send Momo or something, and then the prescription opens. So that's what I did. And so eventually I opened it up to some colleagues of mine. It's called Africa Health Online. Some doctors use it. Myself, I use it for my patients. I thought my laptop would be here to just open it for you guys to see, but since maybe we can have a practical section and see. So there are different types of telemedicine. There's the provider to provider, where, for instance, you are a doctor calling another doctor for help. A house officer calls a consultant to help him see a patient at the emergency room. That's provider to provider. Then there's the provider to patient, where you are directly dealing with the patient as well. And both of them, under each of these categories, we have the synchronous or asynchronous. So the asynchronous one, feedback is delayed. So they may send you an email, maybe a day or two, you check your email, you reply them. That's asynchronous. The synchronous one is when feedback is immediate. The patient calls you on the phone, okay, I'm sending you some medications right now, or stuff like that. Different technologies, we've seen all these in the previous one already. So there are a lot of telemedicine websites. These are examples of them online already. You deal with a doctor to doctor, so you introduce yourself like that. So telemedicine is already in Ghana. Benefits of telemedicine, I'll look at, since most of you are private, the benefits to the private practitioners. So I'm giving a scenario here. A private hospital can get a platform for telemedicine to support ongoing management of chronic conditions and even provide home care for patients. So that's it. For instance, you have some patients who are at home. You have a nurse going there to check their vitals and stuff. They may not be able to come, chronic disease patients, they may not be able to come and stay in the hospital. But you have a nurse going to check their vitals, blah, 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 and entering it on your system. Then you are at home, you look at everything. If you need to change some medications, you change it. And you can even do a WhatsApp video call with the patients, blah, blah. Obviously, they will have to pay for it, but that's an example of telemedicine. Another one is where you have a private hospital, maybe, well, let's say a one-man one-man show, and you need a little bit of specialist input. Instead of, in Accra, for instance, I see a lot of specialists moving from one hospital to another in Black. Sometimes the specialists cannot come and the patients have gone there already. You can set up a telemedicine system, just like we have, the IT team have set up this. Specialists cannot come, and the patients, and they come. Do a video call. Let a doctor be with the patient. Do the video call with the specialist. Let the specialists deal with the doctor whilst the patient is there. Interact with the patient. Whatever prescriptions the specialist wants, talk to the doctor on the ground. Let them just issue. And you still get paid for. And you pay your specialist as well. So these are some of the things you can do. So seriously, with IT now, you can have a small clinic, but with your connections with big specialists all around, you can provide many services, dermatology, whatever, and still charge your specialist fees. Because the specialist is still dealing. These things are quite new. Government is now even struggling to get some of these policies done. Reimbursement is also an issue if you are dealing with any. I don't know how they are going to reimburse you. Patients' concern sometimes. Some patients want to see a doctor freely, not virtually. And then that's it there. A few best practices. You want to make sure although you are doing your teleconferencing and the doctor is talking, you want to make sure you have a platform where the doctor can enter the prescription, not just talk. Because somebody will say, give 15 milligrams of diazepam. And somebody will hear 50 milligrams of diazepam. And by the time you realize, they've gone to give 50. And now there's trouble. And the specialist said, I said 15. And the nurse is like, I heard 50. So sometimes documentation is important. So although you can talk by conferencing and when it gets to these things, it should send you the written instructions. Okay. Well, these I'll skip. This just make sure your webcam is ready. You test your microphone and all that. Be sure your internet is up before you let your patient come in. Okay, so the future of telemedicine. Do you think telemedicine has a future in Ghana? Oh, okay. So we think telemedicine has a future in Ghana. There's actually a government policy on telemedicine. If you look at it, the Ghana Health Service Policy and Strategy on Digital Health, it's actually aimed at 2022 to 2027. So you can download it, it's online, and read about it. The aim is to establish a national telemedicine service for rural and remote communities. So they already have this policy, and they wish to have telemedicine in Ghana. I don't know whether it's the medical practitioners who are slow in adopting it, but that's why we are having some of these conferences so that we all get to know about it. So the future of telemedicine, it is in anyway. We can use it in chronic disease monitoring, mental health, etc. And AI would also augment the telemedicine field as well. Okay, so I've already mentioned the suggestion like the domiciliary medicine. So we are getting a lot of people who are having strokes and stuff that are at home. And sometimes if you are running a private clinic or something in your district, if you have nurses that can go around to take their vitals and stuff for them, they will prefer it rather than bringing the patient for review in a wheelchair or something, especially those that are bedridden and stuff like that. So you can use a little bit of technology and make money out of it. And most of those bedridden people, they have sponsors from outside. I have a patient like that. The nurses go check everything, send me the information. I talk to them on WhatsApp call, but then the son is in the US and is willing to pay any amount for that service. Because I can't always be driving to the house and stuff, but there's a nurse close by that can do that for me. Okay, so in conclusion, innovation in healthcare is not about replacing doctors. It's about empowering doctors with better tools and data, and the reach. It makes your reach go further than just the small community where you have your practice. I'll end with these questions. How ready are you to adopt technologies in your hospital or clinics? And then what concerns do you have? Thank you. Yes,
Yes, please. Yes, please. Thank you very much, Dr. Bawumia. I have a contribution and a question. Now, regarding the telemedicine, it is not exactly easy, neither is it too difficult. It's highly doable, but your internet must be reliable, and you must, in our setting, you must have a plan A and a plan B. So we have both MTN and we have Telecel, so that whatever it is, you cannot go off, so that your patient cannot see you and all of that. And the same thing at the patient's end. It's only available to those who have internet where they are. The second thing is, for some reason, the patients prefer to see the doctor feely. We have tried to decongest our OPD so that the new patients come in, because for the new case, you have to do a whole assessment. But the review cases, somebody who has had surgery a year ago coming for 1 year review, 6 months review, 3 months review, you can very easily do it virtually by telemedicine. But it has been a struggle to get them to agree to the telemedicine. My mom is going for her 1 year post-surgical review today. She has gone to the hospital because she wants Dr. Sakifio to see her walking well and wants him to look at the wound, and the wound is fine and you're walking fine. You can walk virtually, but she wants to be there to see him. So culturally, we have a lot of work to do. What we have done is to put telemedicine videos at our OPD and play them back to back so that the people will realize that, oh, it's not all that bad doing telemedicine. You get the same quality of care, but they must have somebody on their end also to explain things to them and to help them carry out the actions. In orthopedics, you have to raise one leg, you have to move your arm this way and do that. So you have to get all those things straight. Now, my question is about the medical devices that everybody is taking on: continuous checking of your blood sugar, continuous ECG monitoring, continuous blood pressure monitoring. I mean, won't this give you an anxiety attack? Because 1 minute the BP is 110/90. The next minute something happens, it's gone to 140/90. The next minute is 170. You know, these things fluctuate. You are going to bombard your database with tons of, in quotes, unnecessary data, bombard your patient themselves with lots of data, and bombard the doctor with calls, because every time it goes up, you are calling the doctor. Well, if you wait for some 10 minutes, things will settle down. How are we going to overcome this highly potentially anxiety-laden devices?
That's interesting, and it's a difficult one. This is more like a partly cultural thing, human thing, and the technology is there. As they say, with more power comes more responsibility. You get the power, you have the power to check all these things, but now you also have to be responsible for some of these things. I think it will end up with a lot of patient education, and the fact that once you explain to the patient that these devices are there, but you don't need to do it every minute or every 15 minutes or something, it will allay the patient's fears as well. The other thing is patients themselves. You know, there's this thing about hype. When you get the machine immediately, you want to wear the smartwatch every day. I have 2 smartwatches. I don't wear a watch anymore. when somebody brought it to me from the US, she just gave it to me as a gift. I started wearing it for a while, because of the excitement, and it got to a point. My wife asked me, why are you not wearing? I said, I'm tired. You get me? So that's what happens with our patients. If the frequency is too high, they will rather, at a point, drop it. So we have to maybe look at how we can maybe set it up in such a way that the frequency is manageable, like the use of these devices are manageable, then they can. But a lot of education has to go into it. As for the producers of these things, they are in business. So the more people buy, the happier they are. So there are a lot of adverts everywhere just pushing some of these things out there. And I have a feeling FDA is in big trouble with the validation and approval, because there's a lot of money involved. So I don't think they are thinking clearly. Before you say no to a particular device, the amount of monetary pressure and push that is coming if you are...
Indication of an injury. And it goes away when the injury, is out. And then we have got the chronic pains. And then that lasts for a longer period. And if untreated, untreated acute pains can generate, to a chronic pain. And it persists for months or years, and it can be a mild or severe. Then we have classification, about 3 classification of pains. We have got the somatic pains, which is a sharp one and it's a localized one. And worsen when you touch or the affected area is moved a little. When somebody has got the dislocation, that's why when you had an accident, they say manage the people well. Because if you don't manage them, as soon as you hold some part, you say, that means the place is paining him. That's the somatic one. And it falls under the skin, muscle, joints, bones, and the ligaments. And then we have got the visceral pains, and it's felt in the internal organs and the main body cavities, thorax, abdomen, and the pelvis. And I'm just rushing through, because I don't want to take much of your time. And then we have got the nerve and the neuropathic pains. That comes within the nerve endings and the nerve system. And the nerves between tissues and spinal cord. And the nerves between the spinal cord and the brain. That's where we have the somatic, nerve pains. And then continue. The 4th one is sympathetic pains. If you see the word sympathetic, that means it occurs after a fracture. And from soft tissues in the limbs, and the injured nerves becomes unstable and fires off random abnormal signals to the brain, which interprets them as a pain. The nerves send a message to the brain and interpret it as a pain. That is another classification of this. And then referred pains. That is very interesting. It's a reflective pain. And the pain it is felt somewhere, but the originating of the pain is another point. And there's like the heart attack. The pain is felt around the shoulder, back, and neck rather than in the chest. Sometimes, the causative point is there, but you feel it at another point. That's the referred pain. So, pain management. Underlying disorder. When treated, sometimes the pain will not be felt, it will go. And there's a use of analgesics, for nociceptive pains, and the use of other drugs to manage in the chronic pains. And here I'm zooming up to the different types of the analgesic. We have got opioid analgesics. The one that you take is narcotic and sedative. And so sometimes we do normally give mostly to repetitive to the patient because they become addicted to it. Somebody being given Sosigo injection or Petidine, we will give it sparingly, at once or twice, because we know that the person will become addicted to it. And then we have got Then an opioid analgesics, they are not additive, and it's mild to moderate pains, and relieves, effects become dwindle as time goes on. And then we have got the NSAIDs. And the NSAIDs are dose dependent. You have to increase the dose to take care of the pains. And but we have low doses of it. As is for the head pains, muscle ache, and minor, injuries pains. And there's also a high dose reduced joint inflammation. That's where you want to reduce the inflammation for a shorter period, so you have to use a higher dose. But most of the NSAIDs that you use are of lower dosage regime. So, what are the types of NSAIDs that we use? They work and block the production of prostaglandins, which cause pains, inflammation as well. The prostaglandins, they are the causes of these things, and then it generates, and then it produce prostaglandins, and the COX help it. The enzyme also help it to produce those prostaglandins, and then you start feeling the pains. So you use this type of analgesics just to block the effect of the enzymatic effect that will change it. Those processes, and to enhance the processes. So we block it so that the pain will reduce. And most highly utilized classes of pharmaceutical agents are the NSAIDs. We have a lot of NSAID in the system. But what type of NSAID are you to use? Especially when you got a patient with various GIT programs and all those things, we have to choose and select the type of NSAID that you have to use. We have the traditional one. We have got the COX inhibitors, COX-2 inhibitors. And then we have got the salicylates. And then we, as MNG, we are focused on the use of Easypen. And the Easypen is aceclofenac plus paracetamol combination. So it's a fixed dose combination of paracetamol and aceclofenac that we use. And we have a trust in our product. And I know a lot of you people or doctors here have been using the Easypen for managing pains. Is exceptional, and we know the reason why ours is very exceptional from the other combinations. Because you see, you can take paracetamol, you give it the same quantity, the same dose of paracetamol to produce paracetamol tablet, but my manufacturing practices and what I put in will make my paracetamol different from the other one, the other factory also will produce. So I know what the tricks are used in producing my paracetamol, so that it can easily be dissolved and go to the action point when I want it to be. Exactly that's what the Easypen is. I know that a lot of people have been producing aceclofenac paracetamol, but I have a belief in my Easypen because of my manufacturing practices. And I know what it is, the disintegration time, how it moves to the action point, how it binds to the protein, how it goes to take care of your disease. I trust it. And I cannot buy for other people, but I buy for mine. That if you take Easypen, you are going to have your problem solved easily. Your patient will come and thank you. As I said, this is the composition of Easypen. It's got aceclofenac. It's an NSAID. And it's used to relieve pains and inflammation. Also effective in the dental pains and the gynecological pains. And if somebody comes to you to uproot a tooth, and you give Easypen, to take, within a short time, the pain will be relieved. The person will not come back to tell you that, especially when anesthesia that you put there is gone, and the person starts feeling the pains. That means that's where the person will call you and ask you, doctor, I cannot withstand the pains. Then you tell them, Easypen is there, go and take Easypen, just one tablet, twice a day. It's well tolerated. Aceclofenac is well tolerated. And there's got a sort of qualities, pharmaceutical qualities, which are better tolerated in the GIT, in the gastrointestinal tract. There's no need of a half ulcer, so I cannot take it. That one is well tolerated by those people who have an ulcer. So incidence of gastric osteogenicity is very lower than the other frequently used NSAIDs. And this has got twofold lesser activity for such gastric osteogenicities than naproxen, than okay, I'll finish the answer. Than the diclofenac, and then the other for indomethacin. I don't think this time I haven't seen indomethacin this time. It's well absorbed pharmacokinetics. It's very well absorbed in the GI. It's very tolerable by the GIT. Peak volume by 3 hours you have got. It is 99% protein-based, so it tracks it to the system where it's supposed to act, and then it releases to the place and it starts working. It's eliminated completely, 70 to 80%, and the rest are squeezed in the feces. Half-life time is about 2 hours or 3 hours. It's clinical proven analgesic antipyretic agent for paracetamol. I'm talking about paracetamol now. You see, the combination is a very interesting thing. When the paracetamol, as soon as you take the tablet, it disintegrates, and the paracetamol is absorbed quickly in the system. And in paracetamol, within 30 minutes, they start 30 seconds, it start working, and then to reduce the pain, because it lowers the threshold value. It raises the threshold value of the pain. So it takes, quick time to person to release. So after that paracetamol has lowered, the pains, and it can also penetrate through in the membranes of the brain where the peroxide tone is very, very, low. And then when you have paracetamol working up, then when it start draining off, then aceclofenac will start. The aceclofenac will something like it brushes off and sweep up the pains, because it takes a longer time for it to act. So paracetamol started very quick, and they work in the synergism, to potentiate the effect of each other, so that it works very well. Because my time is up, that's why I'm, rushing. I've said all these things. It's very effective. And then, if you give it to your patient, you are sure that your patient will not come and worry you anymore. For severe pains, inflammation, rheumatoid arthritis, osteoarthritis, ankylosing, spondylitis, low back pains, dental pains, gynecological pains, inflammation condition of the ENT, fast relief of headache, muscle pains, and fever conditions. This is aceclofenac. That's how we packed it. We have 2 packs at the moment. We have got the one which is packed in singles that you can just give your patient. And this one is 5 inside, and you can easily pick. It's 6 tablets in a stripe. 1 type twice a day, with or after meals. And then for 3 days, it's okay. That's the dosage. And then thank you very much for it. And I told you that I won't take a long time. I'm finished. And whatever, if you want to ask any more questions, then I can elaborate. But if my time is limited, then I hope I've explained everything very explicit. So maybe you don't have any questions to ask me. On that note, I thought you were going to clap for me. Oh, yes.
The questions will come.
Right.
Thank you very much. Please have a seat.
Thank you.
Now we invite Enterprise Group to come and do a presentation. After Enterprise Group, then the questions will come. So MJ, stay around.
There is something that drives you. The very thought of it fuels you. And even when the road gets rocky, you keep going. Just to get the results that matter. It could be about you. It could be the lives you touch. It could be about something dear to your heart. Such results leave a sweet lingering smile, a sense of fulfillment. That's why you work till late, yet rise with the sun. Yes, your drive knows no limit. Do it with Stanbic Bank, where we spur you on to get the results that matter.
Good morning, or almost afternoon. All right. My name is Emmanuel Aja from Enterprise Life Insurance, a relationship manager. I'm here with a few of my colleagues, Koma, Presla, Mabel, and then Neil Ante, and as well Sabina. Yes.
That's the enterprise group.
Yes, please. Okay, so I'm going to talk about the enterprise group today. So enterprise group has been in existence for 100 years. Last year, we celebrated our 100th anniversary. So this year, we are 101 years old. We're the first insurance to come to Ghana, and we've been a trusted brand over the past 101 years old. This is the enterprise group today. We have the enterprise insurance that insures our vehicles and other general insurance things that we can put value on, our houses and other things as well. They handle, of course, our professional indemnity. So if you need any professional indemnity for your facility as well, you can contact us on it and then we'll handle it. Then we have the enterprise life insurance. The enterprise life insurance deals with the life insurance products, the education policy, the personal life cover that you can do, and other things. And then we have the enterprise trustees. The enterprise trustees takes care of pension fund management. So the tier 2, the tier 3, provident fund, personal pension plan, they manage those funds. So if you need a tier 2 or provident fund for your facility, you can contact us and then we'll deal with it. And then we have the Acacia Health Insurance. If your facility, we all know Acacia Health Insurance as well. If your facility is not enrolled on the Acacia, you feel your clients have Acacia and then you want them to access your facility, you can contact us and we'll get it done. And then we have the Enterprise Properties. Enterprise Properties is a real estate company that manages properties and then also put up building. If you want any of our properties, you can speak to FNB on, they are the partner brokerage bank on that. And then we have the Transitions, which is the funeral home. So the Transitions is at Hacho, and you can contact them for any of the funeral services that you would like to take from us. It's a one-stop shop as well. So this is a partnership we've had with Ghana Medical Association ever since in 2016. Yes, so we are the top sponsor for Ghana Medical Association. Okay, so we are going to talk about one particular product, which is the most reason for being a partner to this particular event today. The package name is the Executive Plus Plan, which is from Enterprise Life Insurance. The Executive Plus Plan, which is from Enterprise Life Insurance. It's a life insurance policy which is a very comprehensive in nature, and it's a premier life insurance you can ever find in Ghana here. That the terms of it were carefully negotiated by Enterprise Life Insurance and Ghana Medical Association in 2016. I would like us to do a short practice that will take us 1 minute. Yes. People are asking why life insurance in the first place. Okay, so let's do this practice. Kindly take your phone, switch to a calculator mode, then type how long do you have to go on retirement. If you're already on retirement, just type how long you think you want to play with your grandchildren before you leave the earth. Yes. And then please multiply your current total monthly income by the number of years left for you to go on retirement or you wish to leave the earth finally. We all have that goal. That I want to play with my grandchildren after retirement for nothing less than 30 years. So I want to be 90 years old before I die. I don't know about you. So you can do that as well. Please multiply it by 12 months. So this is your monthly income. So you multiply it by 12 months. Congratulations. Hooray. This is the amount you are worth now before you finally depart the earth or before you retire. This is how much you have to bring onto the table to take care of your grandchildren's school fees, to take care of your bills in the house and other things, your housing loans, your company and other things. What are we trying to talk about over here? So when it comes to this package, we are saying that the value you have calculated already, yes, it has certain risks around it that can take it away from you permanently. If you got 5 million Ghana cedis or you got 2 million Ghana cedis, that value, it is not there forever. It is not there forever. One day, one thing may happen and it will take it away from you permanently. The thing is that when that thing happens, what are we going to do, especially those that are dependent of ours, our children, our grandchildren, and other people that we are taking care of? What are they going to go through in our absence? So Enterprise is saying that in the event that critical illnesses or you suffer total permanent disability or finally you die, we are assuring you for that value that you've gotten. That is what we want to do on this package. So this package covers you from a minimum of 200,000 Ghana cedis to 5 million Ghana cedis on critical illnesses, total permanent disability, and then death. From a minimum of 200,000 Ghana cedis to a 5 million Ghana cedis. And even when you want more than a 5 million Ghana cedis, we can do, we can write an express or we can write a separate underwriting for you, and then we'll insure you for that value. Some people will say that, oh, I have a lot of money, I don't need insurance, I have my assets they have built and all those things, I have my company, I have my own hospital I'm managing, I don't need life insurance. But in my view, or in the perspective of insurance, it is not so. You know what insurance does? When these three things happen, death, critical illness, and total permanent disability occur to you, insurance comes in to buy you that time before they finally get hold of managing that asset. You are rich, you are very smart, you are very tenacious, and you've been very resilient. That's why you've been able to accumulate all these wealth for yourself. But do you think your children are that smart too? Or do you think they have that grace that you had to be able to do what you did? But the insurance company comes in to help them buy that time before they jump on to managing what you've left for them, especially when they are very young. So when it comes to critical illnesses, there are defined illnesses that are covered under the insurance package. So we have stroke, heart attack, cancer of the blood system, brain tumor, other solid cancers, paralysis, major organ transplanting, which includes the liver, kidney, heart attack, the heart, the lung, pancreas, and bone marrow. It also covers kidney failure or other CKDs that requires dialysis. It covers major burns, rheumatoid arthritis, lupus, thyroiditis, Crohn's disease, and then ulcerative colitis. So these are the critical illnesses. It goes on and on. Lymphoma, leukemia, they are all part of these illnesses that are covered under the package. So these are chronic illnesses. We are all medical practitioners here. This is not the first time seeing it. We know it is they are very expensive to manage. They are very, very expensive to manage. My dad had stroke before he passed, and I really can recall the number of times we've been to the hospital. It wasn't easy. I spoke to one doctor at the Greater Accra Regional Hospital shortly before I came here today. I was asking him that, right now, if you want to correct a stroke, how much do you think is needed? He said nothing less than $35,000 has to be deposited before. So imagine you don't have an insurance. Are you going to liquidate your assets, your hospital, or the big investment you've accumulated for yourself for that particular, to solve or to give yourself extended life if you should get a stroke or even a heart attack, cancer of the blood system? These are very expensive. And they are becoming common, most especially the CKDs. They are becoming common. A research document I read from WHO page recently is suggesting that it is only 2 out of 10 people who are able to live beyond 60 years old. live without any of these illnesses. It is only 2 out of 10 people who are able to live beyond 60 years old are able to live without any of these illnesses. Meaning the 8 of us there, before we die, our post-mortem, our autopsy is going to prove that we've been living with any of these illnesses. Enterprise Life is saying that should you be diagnosed with any of these illnesses, they are guaranteeing you a sum assured between 200,000 Ghana cedis to 5 million Ghana cedis. And it is up to you to make that decision to insure yourself. Life insurance is very important and it's needed in our life, in our daily life, because we don't know what happens tomorrow. The patient that walks up to you today, to your facility, to be taken care of with these illnesses, didn't call for it for himself. He didn't pray for it that today I want to be diagnosed with critical illness. I'm happy. I'm going to the hospital today. I want to be sick of stroke. No. It just happened and it is unfortunate. The money, if they don't pay to the facility, I don't think you'll be happily taking care of them for free. Not at all. So if you don't take this particular package for yourself, I believe you aren't doing yourself a very good service. So this is the package when it comes to critical illnesses. Alongside, we said it covers total permanent disability and then the final thing, which is death. Death is certain. We'll all go through it one day. Ghana, we are mourning now for the tragic incident that has happened. They never wished it for themselves, and it is a very tragic incident. We are not praying that any of us go through that same incident. Never. We pray that God give us the strength and then the grace to live long to play with our grandchildren. However, anytime it happens, Enterprise is guaranteeing you your sum assured between 200,000 cedis to 5 million Ghana cedis. There are other things on this package that it covers. Hospitalization cover up to 1,500 Ghana cedis. This is saying that anytime you are admitted in the hospital, you are on admission for at least 2 nights. Enterprise is saying they are going to pay you 1,500 Ghana cedis, multiple. Thank you for pardoning me. Thank you for pardoning me. We'll give you 20% of your premiums contributed every 5 years if God has been so gracious with you for all this. 1 policy number, 1 premium deduction, either monthly, quarterly, biannual, or annually. Waiver of premium when you attain 60 years. This is good for those of us who are still below 50 years and want to sign on. We are saying that should you sign on before attaining 50 years, once you get to 60 years, you are not going to pay any premium again. Free, forever. Yes. We all know that after 60 years, that is when our risk is very high. Isn't that true? Yes. But on this package, because GMA was in the picture when we were negotiating the terms, it said that a waive of premium payment for all my people when they sign on after 60 years, because they are not going to get money to pay again, they have retired. We don't want you to break into your retirement fund to be paying for insurance. So after 60 years, stop paying. That is it. But anytime death should happen to you or critical illness should happen to you, we'll still pay the sum assured you selected. However, if you signed on after 50 years old, you are only paying for 10 years. So if you were 55 and you sign on, once you get to 65 years old, you stop paying. Beyond, you are still covered. Isn't that a good news? That is it. And then there is a dedicated relationship manager that is going to assist you on this package. When you read the name of the policy, it says Executive Plus Plan. It's not that regular kind of insurance policy you've been hearing about, we've been chasing you on. No, this is a comprehensive, a hybrid one. So we manage it in a special manner. We'll always be with you. Anything you need concerning insurance, there's somebody there to assist you from Enterprise Life. Somebody will say that, oh, what if the person retires or resigns from Enterprise? Someone else will take over and contact you. All right. And then a free annual medical screening on this package. Every year, we as a company want to be prepared. We want to be very prepared. So we want you to go for your medicals, paid fully by us, and know and advise ourselves if something is about to happen so that we know. That's all. We also want to advise you as well when you are aware that there is something kicking in, the doctor is starting advising you of your BP, of your sugar level and cool. Yes. This is a very comprehensive medical screening, and we do it at either MDS Lancet or Impact Life. It is fully paid by us when you are on this package. And when you are on this package to your birthday, it's a very, count it on us, put the bills on us. We'll come and celebrate it for you. Thank you very much. We are going to be around till the end of the program, and we'll be in touch. If you need to have any contacts or have further discussion on everything I've spoken about, we'll gladly do so. To know your premium, how much you would like to pay, it depends on your age and how much sum assured you are going for, how much savings you want to do for your children, and how much personal retirement savings you want to do for yourself. Thank you so much. So I'm here.
Thank you so much. But we still have some questions for you. So MG, please sit over there. We'll ask you a few questions. He's been speaking a lot, so he's so tired. So Sabrina, be ready. Your group, we can call on you to answer, the questions. So please, it's time for questions. And let me remind you that we are live on all the social media platforms. So comport yourself. And
thank you. To the Enterprise Life, I heard you talking about the total sum or the total amount to be paid. You mentioned something about from 200,000 Ghana cedis to 5 million Ghana cedis or so. These are fixed amounts. My interest is what do you do about it to correct inflation and stuff like that? Because let's say I'm 40 years, I decide to sign on to something, you've guaranteed 5 million Ghana cedis. Ghana's inflation is just like the waves in the sea, goes ups and down here and there. By the time I'm 60 or 65 years, if inflation has been doing year on year 30%, 45%, whatever, that 5 million Ghana cedis that I signed for may just be able to buy bread. Or I don't know how you are going to correct that. I just want to know about that. Thank you.
Another question, please.
The question goes to Enterprise. You mentioned that life insurance, or is it funeral policy, you can take it 10 to 15 years. After that, after the period elapses, do you have to renew it, or that's the end? You continue enjoying the policy. The second question is there any age limit to any of your policies?
Okay, Enterprise can start answering.
Okay.
You can answer the first one. Sabana will answer the second one.
Okay, sure. That's fine. Okay, so when it comes to the inflation, on our packages, all of our packages, we have something called inflation protector or inflation escalator. What that does is that it protects your sum assured against the depletion caused by inflation. So it starts from 5% to 30% too. So we have 5%, 10%, 15 or 20%, yes. What that does is that should you install, let's say, a 10% inflation protector on your package, it increases your sum assured by that percentage, whereas inflation was not caused by we, the enterprise company, as well, neither caused by you. The advice is that your premium also goes up by that 10%. So you may start with, say, a 500,000 Ghana cedis life cover, and you are 40 years old. In the next 20 years, if my math is right, if you installed a 10% inflation protector on it, let's say the incident is happening when you are 60 years old. Yes. That 500,000 Ghana cedis may be 1.5 million Ghana cedis. So that's the inflation protector. Okay. So the second question was whether, okay, Sabina, you can go ahead.
Okay, so thank you for the question again. So the second question about the tenor, what if after the tenor, what happens? So we give you two things. It gives you a premium waiver or a premium refund. So let's say in the 10 years, nothing happens. You have the ability to call for a refund of premium, or there will be a waiver. And with the age it's up to age 100. Up to age 100, please. Thank you.
All right. I elect myself to ask a question, since I can't see the MC. All right. It's just to say I witnessed the funeral sessions of Enterprise just about a few weeks ago, and their cars are very nice. Even their drivers, the way they wore their suits, and oh my God. Then I said, this man is definitely going to heaven. Immediately, somebody who had visited said, who are these? I said, they are the insurance people, Enterprise Insurance. He said, I have to be there. So this is just to say, I have witnessed the good thing about your funeral policy. And I have people who have already decided to be on it. Thank you.
Thank you. Thank you so much, sir.
Good. Any more questions? MGP is around though.
Okay, what I would say that I told you that when I was doing presentation, I made it very explicit. So everything that I said was very explanatory. So what I would tell doctors here is that tomorrow we are going to mount an exhibition, and we are going to give you something good. So come to we are a fan of giving you nice packages. So if you want to get a bag, the ladies, you want to use it to go for market, or the men, if you want to go and give it to your wife, not girlfriend, wife, So you come and visit us on our stand, and you enjoy it. And I hope that that sort of relationship and friendship between MNJ and Society of Private Medical and Dental Practitioners will be very great, because we have been with you for a long time. Even though sometimes in time I used to fight with you people, but today they've given me a nice platform to this. And last time it was a little bit, but Dr. Morrison corrected it, so now we are good friends. So come and visit our stand, and you get something good. Thank you.
Yeah, I have something for MPG. MNG. Yeah, the other day somebody came to my clinic, and we give a certain combination of analgesics. Then he said he wanted Ezipen. So it means you are known. Thank you.
Thank you very much. Our Ezipen is good. You see, we believe in the drug manufacturing. It's not just manufacturing the drug. There are a lot of things that goes in. Your R&Ds, that research and monitoring and all those things, and then the way the good manufacturing practices that you occur, and the way that your laboratory is also very efficient and all those things, we put so many into consideration. So you don't want to take a drug whereby when you take the drug, you take so many times hours before it will disintegrate to go to the site of action. No, it has to go to the site of action. So if you're a doctor, you are interested in the quantity of drugs that will go to the site of action to work so that your patient will feel fine. That is the type of drugs that we produce. So when you get M&G drugs, you are there. Thank you.
Let's give them one last round of applause. Yes, thank you very much. We are breaking. Walk around a little bit, experience the PEMPAMSIE Hotel and its surroundings. It's a nice place. You come back at 1:30 after you've had your lunch. Thank you very much.
understand.
Action. Robotic prostatectomy. Okay? And we don't have it here. Sometimes we have to face inconvenient facts. In some of our southern hemisphere cities, they have like 20 robots. This is Da Vinci robots. Where no, we don't. But that's the procedure he chose from the feedback. So we would understand a lot of these new area when we go through this by the last day, Friday, when we finish with the scientific sessions. Our take home on these matters will be good. We are still waiting for our system to kick in. I can. It's very short, yeah. We may decide to make some shifts if the system still can't pick his login and his presentation. We actually tried it. So I would like Dr. Akwa to be ready. That is, we are going to shift. We are going to shift to lecture 4, where we have. Okay. Are you on with him? What did you say? I actually walk around this with them because I know. Okay. If we cannot get him on the screen,
link. He practiced with them already. Okay. I'm told these are working. It's not now. That's okay. So we would, whilst they sort out the IT for Dr. Akin's presentation, just give me a moment. I got another link from them. So let me send it to him. We sent the link, we troubleshoot, and everything was right. And their system went down. So I think when it came back, they have to send another link. Their system here. Yeah. So he's gotten a new link, and he will soon be on. I hope that he's still keeping everything else intact. Apologies, please. Okay. What we will do is we will move to Dr. Aqua whilst they sort out, because he said the link is not opening for him. I have sent you his number, so you can send him the link directly again. Are you on? It's because he said the link is not opening, unlike the previous one. Okay, so I think we will change. We will move to Dr. Aqua. Let me read a little bit about him. The pointer? No, I'm sure it. So we'll move to the lecture, the next lecture, which is the lecture 4, and it's artificial intelligence, assisted surgeries, and robotic advancement. I'm sure you heard about Dr. Aqua's profile. I mean, you listened to it this morning. So I'm not going to bother you anymore because our time is spent. So Dr. Aqua, you can we give him a hand? So take it away.
Thank you, Dr. Nagai. Thank you all. Good afternoon. And welcome back to welcome to this afternoon's session. We'll look at AI-assisted surgeries and robotic advancements. So my name is George Akwa. I'm a computer scientist. I'm a public health physician too. So we'll see how we can use AI to perform surgeries, how we can use AI to manage surgical conditions, and then how robots are used, what's pervading in the field of robotics, how we can access some of these things as a country, and the future and what it holds in this arena. So AI and robotics are transforming surgical practices globally. AI improves decision-making, robotics enhances surgical precision and reduces recovery times. So we are going to explore these to see the benefits that robots are bringing onto the game. So robots confer precision, dexterity, fine touch. We are looking at filtering tremors so that surgeons can maneuver tissues with greater precision and accuracy and avoid unintended injuries. We are looking at greater degrees of freedom with the manipulation of robotic limbs, and that allows robots to be able to enter cavities that will be difficult for humans to enter in the human body. So, for example, we are looking at conducting cardiac surgeries without having to cut open the thoracic cage and things like that. And by so doing, we are able to get patients to be up and about. We are able to reduce complications. We are able to reduce costs, and we are able to improve overall outcomes. We are looking at using AI to make predictions, whereby we are looking at predicting complications. Out of 100 hernia operations, how many are going to break down? How many are going to go septic? Out of statistical calculation from historical data. Predicting outcomes, how many are likely to survive, and things like that. AI is excellent at making predictions, hearing again. So we shall see all these. The field of AI is very broad, and it encompasses subfields like machine learning, deep learning, computer vision, natural language processing, and some other areas too. This session will not permit us to go too deep into the sciences behind these, but it's worth knowing that AI makes the computer able to see. And it sounds a bit straightforward and a bit familiar with our thinking. We might feel computers are supposed to see, but the task of a computer recognizing this man, maybe Dr. Victor Asari on this screen over here, is a very huge task. It has to convert every single pixel in this image into some zeros and ones of the sort, and then use very sophisticated algorithms to be able to unravel the hidden meaning behind it, which is a very serious issue for it. But thanks to advances in science and technology, they've been able to do this. Machines have been able to do this with so much accuracy now that that task of breaking down images has become so fine now that they can break images down to even sub-microscopic levels. So what are we saying? We are saying that if a computer takes a picture of this man, it can see it better than your naked eyes can do. It can decompose the pixels in here so well, so fine, that you may be able to even see the pores underlying the skin. And therefore, it means if you and a computer should look at an X-ray, the computer will see so many things that your naked eyes cannot see because of this enhanced computer vision ability. And by extension, it means we are now diagnosing cancers way earlier. The computer can now visualize a mammogram and pick up cancer lesions, changes subcellular, changes in tissue years before the human eye's resolution can pick that up. So these are some of the benefits technology confers to us. Now, some core AI technologies we may be concerned with for the purpose of this lecture. Let's just understand that machine learning encompasses things like predictive analytics and risk stratification. These are big words. What they mean is that they are a set of AI algorithms, or let's put it this way, softwares or tools that are able to make predictions. Common machine learning algorithms we've all encountered in lower years of school include things like linear regression, logistic regression, if we all remember a little bit of math, whereby we had the x-axis, the y-axis. We could plot a set of points that had a relationship between the x and y-axis, and after gathering so many points, you could obtain a line of best fits, if you all remember something like that, and then the line of best fits then becomes a predictor. That's an example of prediction. There are several examples of these algorithms, what we call clustering, support vector machines, gradient boosters, and all that, but that's not the focus for the lecture. But just to make you understand that AI can use these mathematical tools to make very good statistical prediction. And as doctors, we can use this in our OPDs, feed the computer with historical data, and it will tell you that out of every 1,000 cesarean sections that you, let's say Dr. Kofi Mensah, does, maybe a 30 of them end up with sepsis. A 30 of them end up with their wounds having to break down. A 30 of them expire or something. Then it guides you in your decision making. That for every number of cases, you are likely to end up with this. So resource allocation, make available things for the future. What factors are associated with these people? Then you pay attention to more high-risk people and all that. So you can use these, and these are readily accessible. All what I've been saying so far, you can readily do with your ChatGPT wherever you are, and it's that simple. You can readily upload files or pictures or PDFs or documents of all your patient's notes, maybe over the past 5-10 years. You can get some young boy or girl to upload them onto the ChatGPT, and it can build a database of your patient records for you, and it can give you a very nice graph, tell you how these predictions are going, and it guides you in your preparations for surgery. Computer vision, like I said, is that field that enables computers to recognize tissues and organs in real time. So you, the surgeon, you are there manipulating the bowel and other things. There are microbleeds going on which your eyes cannot physically see. But with computer vision, we have enhanced vision, and this can make you know that where you are navigating, there's a 70% chance of maybe cutting a nerve or a vein or an artery. So it's better you use this route. So at the end of the day, you carry out your surgery and it's bloodless. And it's that simple. Right in the operating room, you can have your ChatGPT on, whether a tablet, a smartphone, anything, and then you could obtain sequential videos, sequential images, and it could guide you as such. It will readily recognize what you are doing, and it will guide you. If you wanted to annotate for you the anatomy of the tissues in question in real time, it can do so. So maybe you are in the bowel, you don't know which segment of the bowel you are working with, whether the terminal ileum or the hepatic or splenic flexures or whatever tissue it is, and whatever vessels are feeding them, it will label all of them in real time for you on your smartphone. Then you could use it to navigate your procedures as you go through the surgery. Now, natural language processing is that aspect of AI that enables computer systems to understand text and reason. So computers now can understand text, they understand literature, they can understand context, and then they can respond to answers even better than humans would do. So they can process, their processing ability is great. We can use this to interpret, for example, surgical notes. Often surgeons are in a hurry after theater, and then, they scribble things, and sometimes it becomes difficult to decipher. This NLP ability can be able to transcribe the notes. First of all, to make the handwriting more clear. Secondly, to make the notes physician-friendly. In other domains, maybe pathology or radiology, they may use certain terms in certain ways which can sometimes be challenging for us to really decipher what's going on. Maybe 6 inches, centimeter, well-defined, hyperdense lesion, obstructing this, doing that. At the end of the day, the clinicians don't. But you can just feed this same radiology report or pathology report into your ChatGPT, and it will decompose it and make it physician friendly for you. It will give you the context within which the radiologist is speaking, and then the intent of the radiologist. So, for instance, the radiologist might mean that maybe this object is something well defined under the liver, but based on how the description was constructed, you might convey the understanding that the object is in the liver. So then what the NLP does is to break this down and then make the statement very clear to everyone. Then we also have another field we call reinforcement learning. Reinforcement learning teaches robots through experience. So robots learn as opposed to what we think. We've always known robots to be static machine entities. They just move, touch this, do this. No, the AI-driven robots learn. So they track the course with some calipers or some artery forceps or something, and then they ended up cutting this nerve. Trust me, the robot will never do that again. Humans, as stubborn as we are, will keep treading the same course, and then we'll say, oh, it's a complication of the surgery. But robots learn through reinforcement, through hard code, and they avoid this error. Deep learning drives complex imaging analysis. Okay, so let's see a few robotic systems. A lot of robots are in the system, but for purposes of surgery, we make use of commonly of the Da Vinci system. Now, the Da Vinci system is made up of 3 parts. As we see in the screen over here, we have the surgeon by the console, then we have a computer or control system, and then the patient side where we have the manipulator or the robotic limb, as we see in the screen over there. So the surgeon sits by the console and then drives the machine. Often the patient side is under the assistance of a healthcare personnel, maybe a theater nurse or a junior surgeon, who will make sure that all the other instruments the robot needs are within the reach of the robot, so that when the surgeon moves the gears, is able to pick up whatever it wants with ease. Right, now let's look at the basic structure of a robot. What we see here is an example of a robot. This device over here basically identifies objects in a factory setting and conveys information about them. So for any given robot, we have sensors. This could be the form of light, it could be the form of laser, sonar, radar, etc., where sensors are made from. Then we have what we call effectors, which include the robotic limbs and the manipulators. We have actuators or gears or rotors which move these limbs, and then there is a memory or processing unit. So in other words, the robot has a computer. You can liken that to the human brain. The sensors can be our eyes and our ears. The effectors can be our limbs, as we see. And then the actuators are, let's say, the joints, the various joints in between the limbs and the torso itself. So a command is passed from the processing unit, maybe move this scalpel and then make a suprapubic incision about 10 cm in a curvilinear fashion, 6 cm below the umbilicus. So it codes and processes all these things, moves with precision, gets there, and then make that incision that we desire. And then there's an electric motor unit which powers the whole thing. Other things to include AI, reality aid. So we have augmented reality, virtual reality. We'll try and see what these are. And they all enhance the surgery. So at the end of the day, the robot has several tools that makes it move and move with a lot of precision. Before we move on, let's try and understand these 3 laws, very essential laws of robotics. We call them Asimov's laws of robotics, and they govern the design of robotic systems. So the first law says that a robot may not injure a human being or through inaction allow a human being to come to harm. The second law says a robot must obey orders given to it by human beings, except where such orders will conflict with the first law. The last law says that a robot must protect its own existence as long as such protection does not conflict with the first or second law. So any machine we design for use as a robot, and when I say robots, I don't mean just the physical mechanical ones, but even chatbots to include our chat GPTs, all those things we interact with on the screen, must conform to these laws, that they must not cause harm, that they must always obey the orders of humans, and they must protect their existence. Okay. Right, so an example of a robot here with the sensors detecting things and moving around and all that. Now let's just see the surgical robots. We've looked at the various parts of the Da Vinci system. A typical robot is what we have over here with assistants by the bed, the various manipulators or arms over there being controlled at the consular end by the surgeon. In advanced world, you could have the surgeon remotely. So a surgeon can be in maybe Philadelphia operating on someone in maybe UK or South Africa or something through internet connectivity. Of course, there'll be someone assisting by the side, maybe a junior surgeon or something like that. We could also have what we call telesurgical mentoring. With that, you have a senior surgeon or a more experienced surgeon interacting through screen. Not necessarily with the console and things, but the surgical unit is there in the hospital. Maybe a junior doctor or surgeon is there, and then this other senior surgeon through the screen interacts, sees the procedure in real time, and also contributes to it. While we don't even have robots in our systems here, for surgical mentoring, we can all do. All you need is just a screen in your theater and internet, and that's all. So you want to do some hemicolectomy or some complex procedure of the sorts, nothing stops you from inviting maybe another more experienced surgeon, maybe from Kolebu, from 37, from any hospital to partake through the mentoring approach, and then it all aids in the procedure. Strengths of a robot, we've talked about dexterity. So robots have limitless degrees of freedoms. I mean, the manipulators or the arms. A typical human arm can only move in 3 directions. You can either flex, you can extend, or you rotate laterally. A robot can have about 8 degrees of freedom. It can move this way, can move that way, can move this way, can move this way, in all kinds of directions. So at the end of the day, it can access hidden areas in the body, posterior cerebral fossa, all those wild areas. Can readily go there, easily pick up fine structures, especially in delicate surgeries like prostatectomies and things like that. These become very useful. Precision. So robots calculate their movements. They calculate their force of action. So I want to pick up this microcapillary from this vessel at the base of this bowel. I will need 25 newtons of force. It calculates it, moves precisely through the distance, and clips it. A human will go in naked, go puncture the bowel, and say it's a complication of the surgery. Well, it's understandable, but if we get these robots, they can help to aid these our procedures. Fine touch, so delicate tissues like the brain. All these require robots to be able to protect our surgeries, to limit post-op complications, and improve surgical outcomes. An example of a manipulator with some instruments attached at the tip, and all these are under the control of the console. This robot over here was used to implant the first human brain chip by Elon Musk. Over there, you can see it's very sophisticated in its appearance, and it does all these wonderful things. So other systems, the Mako, usually for orthopedic procedures. We have the ROSA, and then the Hugo by Medtronic. All these are in the system. The Da Vinci system, currently, Da Vinci Xi is hovering around $14 million, and Medtronic is the supplier of Da Vinci. You could reach them online, and they could assess your facility and prescribe for you based on your needs. In the operating room, let's see how we use AI. We can use AI preoperatively, intra-op, post-op. Let's look at a few preoperative functions. We can do patient selection based on risk using our ChatGPT. You feed in your theater list to it, and it will tell you, begin with this one, or begin with that one. By the time you are done, this man or woman is likely to be hypoglycemic based on risk. From historical data, you feed it, of course. So we must all copy our theater lists and then update, consult ChatGPT for things like this. Simulation of surgical procedures. So the whole procedure can be simulated. If you want a video layout, if you want diagrams, it will give it to you in every stage. Maybe you touched the scalpel about 15 years ago, and perhaps you've forgotten a bit of your anatomy. It will be a great opportunity for you to recap the whole procedure so that everything goes on successfully. Personalized surgical planning using what we call digital twins. So basically, a digital twin is a representation of any physical object in the digital world. So we could create the appearance of that patient on the theater table with the abdomen open, with all the bowels exteriorized, and whatever procedure we intend doing on it, we can simulate it digitally and then see how it will go, potential complications, and then potential things we must put in to avoid these things in real time before we enter. So it's important we plan surgeries using our ChatGPTs. It's a very wonderful tool we can use to plan our surgeries before we go in. Intraoperatively, we can do real-time anatomical recognition. Like I said, if you take a picture of any part of the bowel, ChatGPT will recognize it for you. It will give you the full anatomy. It can even go to the extent of describing the histopathology in layers to some extent for you. With the use of augmented reality, this big thing we see people wear on their head from time to time, virtual reality headsets, augmented reality headsets, you're able to actually superimpose the real anatomy of the structure on the structure you see, and it will label everything for you, all the arteries, the veins, the tissues, and it makes it easy to navigate so that you move with precision and you don't damage tissues inadvertently. Workflow management can be managed with AI, and all the parameters, usually in theater, anesthesia is running several fluids and gases, several vital signs. There's the cardiograph measuring the heart rate and function, SpO2 parameters, respiratory, then the sugar, pulse. All these have intrinsic hidden patterns within them for which the naked eye, human eye, cannot pick up. For instance, we can combine data from all these sources and predict a cardiac arrest hours ahead of time and intervene appropriately. So we have data we can leverage to improve surgical outcomes. We just need to deploy the AI tools. So nothing stops the anesthesiologist or the surgeon, or even if they are busy, the theater nurse or another doctor from intermittently capturing the vital signs with our ChatGPT. Form a database, ask it to analyze it for you, ask it to make recommendations for you. It will pick up a lot of signs and show you so many things. Right. Post-op. So complications can be predicted. Again, like I said, outcomes can be predicted. We can automate surgical notes and summaries. Like my colleague said in the morning, we have Google Board now, which can just type out anything you say. So surgeon is very busy. There's another case that has to come. So you could start giving your instructions verbally. Post-op day 0, we want the patient to be nil per os. We want him to start SIPs this day. We want him to do this and that and that. We want to inject heparin and do this and do that. Just say them verbally to convert them to text for you, and it will save you a lot of waiting time and reading time before the next procedure. We can analyze recovery and rehabilitation data also using ChatGPT. Minimally invasive surgeries can be conducted, therefore, in this manner. And virtually every field, from orthopedic surgeries, can cut bones with precision and can really help. Cardiovascular surgeries, we can enter the thorax without tampering with the rib cage. Neurosurgeries as well. And these robots really improve surgical outcomes. Benefits of using the robots we've talked about: increased precision, consistency, reduce complications, shorter recovery times, data-driven improvement. Challenges: high cost, like we all can tell. The robotic models are very expensive. 15, 20, 30, some as much as $250 million US. So usually it's the very affluent countries that are able to afford these. But I believe now that NDC is in power. Maybe we can buy some soon. Steep learning. I'm not an MPP supporter, please. Steep learning curves. I'm not a politics supporter, sorry. Steep learning curves for surgeons. So it means we'll have to get, we have to train our surgeons. We need to teach them AI, machine learning, deep learning. We need to teach them a bit of robotics and computation. Then they'll be in a good position to understand how the robots work and how they can manipulate them when they physically come down. There's limited access here on account of these reasons, but I believe as an association we could voice out for this. I believe if some hospitals, some individuals can make the bold step and try and procure a robot, and it could lead the way for the country. There are regulatory issues too. Accountability remains complex in AI-related errors like we discussed in the morning. Who do we blame, the surgeon or the manufacturer? We need proper laws to stipulate how AI should be deployed in these things. Bias, data privacy, another issue we also talked about in the morning. So it's important we make sure that AI models are trained to locally reflect our needs. Then we can use them well. Now, in the future, we are looking at fully autonomous robotic surgeries. That might be a bit risky for now, but in the future, we will get there because machines are increasingly becoming more effective and more efficient. So then, I don't know if any one of us who want to comfortably lie down for a machine to take out our cerebellum or prostate or uterus or something. But then, when the time gets there, maybe we'll be able to cross that bridge. Telesurgery using 5G, for that one, we can do even now. So nothing stops us from getting wall-mounted flat screens, 1,000, 2,000 Ghana cedis. You can have about 2, 3 in your theater. Internet is there so that your surgeon can carry out the surgery with the assistance of other surgeons. We can buy in experience. Sometimes you might not have a particular surgeon. Maybe you have only one urologist in perhaps the upper half of the country, and these people are not in a position to travel down. So then what do we do? If there's a general surgeon, we could have some of these screens to assist him to connect to other urologists from the south so that they can at least perform their low-risk urological surgeries there, and by so doing, we're able to scale up services to remote areas. AI-assisted education and training, which has already begun. Now students don't go to class. They'll just pick his phone, ChatGPT, give me a 1-hour lecture on fluid and electrolyte management, add questions and answers. They'll relax in his bed. After that, he'll just copy, upload his past questions onto it, solve it, and give me the answers. And fortunately, the past questions will be asked again, and then he passes and goes through, or he needs a dissertation. Write the dissertation for me, that's it. So really, in as much as AI is useful, it's a problem. If we don't guide its use, and if you don't use it well, chances are that in the future we'll suffer from things like mental paralysis, whereby we will not have the mental muscle. You grow up a generation that cannot really think so well and address issues and are entirely machine-led, which might not be in our interest. So it's important that we find rigorous ways of still training people to go through the normal route, and then we must also train them to be able to use the AI and use it well so that they stay competitive globally. We must not compromise on both sides. Wearables, AI devices for surgeons, these also help. Low resource settings can really benefit from robots from all we've said, and our government must make strides to see to it that we get robots around. And these are entrepreneurial opportunities too for us as businessmen to procure robots, to design chatbots and other things that we can use to enhance our service. So in conclusion, AI and robots are redefining surgery by improving precision, safety, and access. With appropriate investment and regulation, they can address global surgical inequities. Thank you all for listening. Please, the forum is open for discussion, for questions, contributions, comments. You're all welcome.
if you have any questions at this point, you can ask Dr. Aqua in connection with how precise these surgeries are in terms of the challenges in maintaining machines and other things that he mentioned in terms of training, etc. Because we'll have our next lecture to follow this in a few minutes, but we have a period for questions. Yes. I can give it.
Okay, let me start with this. Dr. Aqua, this debate has been going on, whether in healthcare or not. Will AI lead to unemployment, especially in the healthcare space? Because AI is threatening to replace radiologists, threatening to replace pathologists, dermatologists, those that we need the patterns to read and make a diagnosis. AI is threatening to replace those people. So is it going to lead to an unemployment in the health space and probably outside the health space? Thank you.
Thank you, sir. I must admit that it's already begun creating unemployment. Some certain jobs are being absorbed by AI now, and because people have ChatGPT in their hands, they don't see the need to maybe afford an administrative assistant, an accountant, someone to do paperwork and things. In the near future, AI may not take away doctors per se, but that time will come where it will. What's going to happen is that we'll still need medical practitioners to use AI and to validate the work of AI, because they are machine outputs, and in the interest of our safety, even though the machine is saying something very good, we still want a human being to oversee and confirm that. So because of that validatory role, we'll still have some doctors in practice. But in the late future, these systems will evolve to be way more, I don't want to use the word intelligent for, it connotes a meaning of maybe inferiority of human beings, but they'll become smarter. And the thing is, how do you examine someone smarter than you, or validate someone smarter than you? Then that point comes where the AI is so trusted, and then now it obviates the need for humans' input in work. So then maybe instead of the country having, let's say, 100 radiologists, we may want to have just about 10 or 20 to play this supervisory role. And there, because a chunk of the images that they obtain will readily pass through the machine, and any human hands it passes through will also agree with it. Then it becomes a bit of a challenge. And because employment is a business issue, and the businessman is after maximizing profit, then it will turn out that there'll be a reduction in the need for humans in that space. But then AI is also going to create another set of jobs. So that should be the focus now. So universities worldwide, curricular developers and educators should be moving towards the direction of how you can make the careers AI-driven, or how you can produce, for example, doctors who are AI certified so that they can drive the robots, they can use the chatbots. Producing nurses who are AI certified so that they can use the intermediary things that are available now. So when that comes, it means people have to go and train for those things. So we need doctors, but we need doctors who know AI. So that's where we'll be heading to. Another set of jobs are going to be created, and then a lot of the old ones are going to be effaced or phased out gradually.
Okay. Any other questions? Yes, go ahead, please.
Yeah. Thank you for this lecture. But I have two questions. The first one, the chat GPT, is it the one we all have on our phone these days, or is it a special one that we have to get? And do we have to subscribe to it? That's my first question. Second question, I found out that at times the AI is not always correct. They can make mistake. So why they make a mistake, who takes responsibility?
Yeah. Thank you, sir. So, yes, the ChatGPT we all know. Unfortunately, there have been a few fake versions around. So whenever you want to be sure you are using the right one, make sure you are downloading it from OpenAI, the original manufacturers of the ChatGPT. If your ChatGPT is from OpenAI, then you are safe. There are others lingering around, chatgpt.com and all that. A lot of them are fake. But then the original one is from OpenAI. There's a free version, usually a trial version for about 30 days, after which you have to subscribe. You can do the Plus, currently going for around 200 Ghana cedis a month, or you can do the Pro. That one goes for about 2,500 Ghana cedis a month. And then there are other versions too, all with their features. Some are more well-designed for research, some are for reasoning, some are for creativity, some are for coding, for programmers and things. So depending on your field or the task you use it most for, you can subscribe to the appropriate one. But make sure it is from OpenAI, openai.com. Yeah. Yes, so please, your second question. Always right. So there are instances it makes mistakes. We call something hallucinations. Just as we recall from psychiatry, people having delusional perceptions or false perceptions from hearing things, seeing things, and all that. AI too does same. There's actually a mathematical underpinning for it. And the whole prediction machinery could go faulty because it works with numbers. It doesn't feel the real substance on the ground, but it does it so accurately that in about 90% of the time, it leads us well. But there are those times where there could be certain uncertainties that could swing it. For instance, if the data set is not well balanced, then you could ask it, who is the president of Ghana, and to say Donald Trump, and you might accept it, and things like that. It can make very blatant errors. We call those hallucinations. The way to go about hallucinations, one, first of all, you must enter the right prompt. There is a whole thing my colleague talked about, prompt engineering. So if you want to use AI, you must be taught how to engineer prompts. Two, you must be aware of the training data. Where is the data coming from? With ChatGPT, we know it was trained on Google and all its appendages, the internet, several articles and things. But in addition to typhoid, at least majority agree with something. Then you go back, you don't discard what ChatGPT is saying because majority is saying it's typhoid. ChatGPT actually could be right. And then go back, let it give me the references that support your claim of malaria. Then go to Claude, give me your reference that for you to give feedback and let them know that the model hallucinated. It gave you false information, and that's what the patient had was, let's say, typhoid and not malaria, so that they update their system for the whole world to use it in the right direction. So if you go through these phases, you can pick up when it makes an error, and then you will always be using it in the right direction.
Great. Thank you very much, Dr. Aqua. Any more? He's online. Any more questions? Yes, please go ahead.
Okay, so thank you very much once again for the presentation. My interest is on your last slide. You didn't tell us anything about the cost implication for the 3-week training that you have advertised on the last slide. Please, can you throw a bit of light on it? Some of us are already beginning to show interest. Thank you.
Yes, sir. So it's a 3-week online course on AI. It's meant to give participants a fundamental of AI, a good understanding of it. And then in the 3rd week, we try and guide you through how you can apply it in whatever field you are. If you are a banker, we show you how you could. Yes, sir. The cost is 500 Ghana cedis for the whole 3-week program. And there's a discount if you come as a group of 5 or more, it's 350 cedis. And we'll commence this September.
Is it residential? Online. Good.
Okay. Thank you very much. We'll be taking our last question. I hope you are now in sync with Dr. Kuzi. I haven't seen his slide yet. Please. Go ahead, Dr. Andre.
Okay, there's this issue about where AI, just like drugs that we use, when they're developing medications, they do research on maybe Asians and Europeans, but the dosages that they recommend is what we use in Africa. But the research probably wasn't done here. In the same way, AI is learning, is being fed data from the Western world, Asia, and so on, but we don't have much data of Africans, but we may apply it on Africans. And you know that physiology and anatomy may be slightly different depending on one's race or the continent one is coming from. So we may be applying AI technology and recommendations, learn from somewhere, but on a different anatomical,
On Friday, we're going to look at some aspects of what you said, but briefly, you can make a comment. But Friday is going to address these data issue and the training of the model.
Yes, sir. So please, your data reflects the context within which the situation was, the model was trained for that situation. So then, like the statement he made, if you just, then if you say, if you want to know steps, for us, we see just the answers, but there are mathematical algorithms behind it, which like sort of switches the whole radar several degrees apart. So then it will give you certain situations relating to your context. So in every time you ask a question, you must give it context. If you don't contextualize your prompt, it's going to give you generic answers. And those generic answers will be largely influenced by where the model was trained. So if you come out to say that you are an African or you are a Ghanaian, or maybe your patient is in Ghana or is in 37 or Nyaho, it is going to contextualize the answers there. The Nyaho training data might not be so much, but then it will be better than you just opening it general. That one will swing the radar so badly. There's something we call an attention mechanism. It's computed. The whole point is if you give it context, it narrows its search for you. And then with the little data available there, it can do a lot for you. Although most of the data was based on UK, the little in Africa, it will sort out something good for you, which might be even comparable to what we would have had if the model was built in Africa. So it's important that we always state the context in which we are making our inquiry.
Any more questions?
Well, let's give a hand to Dr. Henry Akwa.
Okay, great. So, Dr. Akwa, thank you very much. All right. So we'll move quickly to the next presenter. And I'm still waiting to see if you have been able to pick his presentation. But certainly, yes, there are some jobs that will go with AI. Most jobs that are monotonous and just all the jobs that are monotonous, maybe in the next 10 to 15 years, most of them, yes, would be taken over. But as he said, what we know in the field is that new jobs will be created. It's just like when we were moving from slide rule to log tables to calculators to fast computers now, and then and here where we are. Everybody thought that computers will eliminate everything, but it created a lot of jobs. So that is the prediction. If you hear what Bill Gates said, I think this week, about AI. What I can also add is that if you are able to get the subscribed ChatGPT 4 or above, it's quite a useful tool. I do some AI work and I use it. It's quite a useful tool. If you are paying 2,000 a month for it, and you know what you can do with it, it's amazing. It's I would say it's like what you get is like 20 or 30 times the amount that you are paying. So it's a very useful tool. And what I can add is that when you want to get into the AI area in terms of training, you should be able to know what exactly you are looking for. There are a spectrum of certifications and training across. And sometimes you might go participated in. So you must choose what you need. If you are a manager, you want to understand how to deploy what type of AI product and how you can manage people, that is also there. If you want to be somebody who want to use their, if it's online, can you just, because he said he's been waiting for your projection. That is Dr. Ekins Kuzi. He's located, a colleague of ours who is located in the UK. So you should decide on what exactly you want, so that when you finish the training, it is useful. You can just be trained even on just the prompts. What kind of prompt do you want to give the particular AI to do the work for you? That is very, very important. The other thing that was mentioned by Dr. Aqua, which is very critical, is, for example, the Da Vinci, in a lot of that's the robot that the surgeons can use. It's not the robot alone that does the work, really, that can use. It has improved a lot of the surgeries, outcome of surgeries in countries where it has been used. I think we now have Dr. Kuzi. He's hearing us live. Dr. Kuzi will be taking us on the topic, which was supposed to be the third lecture. That is the role of artificial intelligence and automation in improving healthcare accessibility and outcomes. Dr. Kuzi, I was telling him, incidentally, we seem to be an alumni of the same university in the UK where he is now. That's UCL. Dr. Kuzi is basically a medical doctor, but also an entrepreneur, and he's pursuing a lot of AI-related businesses and training. He's a digital health innovator and passionate about leveraging technology to improve healthcare delivery in Africa. So you hear one of the products called Nemos. He co-founded it, which is an e-learning platform for medical students. One of the last few weeks ago, I passed through Kolebu at Old Medical, and some have this particular product. And you can be amazed at what it can do. It can help you to learn, as it were. And then he also focused on healthcare technology training at the University College of London, where you have the Royal Free Hospitals. Dr. Akins, if you can hear us, you can take it away.
All right. Thank you very much. Can you hear me? Hello, can you hear me?
We can loud and clear.
Okay, great. Thank you for the opportunity. And it's a pleasure to be given this opportunity to talk about this topic. It's really inspiring to see that the entrepreneurs in healthcare in Africa are thinking about how we can leverage technology, and not just any technology, but the modern day and advanced technology in increasing healthcare access and Dr. Nagai mentioned, I am currently doing, I kind of finished my master's now, just submitted my dissertation a few weeks ago in digital health and entrepreneurship. And I went into this journey a few years ago after I noticed and witnessed some of the challenges that we have in terms of healthcare delivery in Ghana and in Africa in general, which I believe are issues that could be solved and can be solved with technology. And that's how come I took this journey of technology, went into digital health and health technology in general. So my topic is on the role of AI and automation in improving healthcare accessibility. So this is a topic that is more like a baseline where um, the other topics that have been delivered and lectures have been delivered kind of already have mentioned some of the things I'll be talking about. And AI now is something that everybody has really heard of and is not new. So this is going to be the outline of my presentation. I'll basically get some definitions out of the way and then go to talk about some of the barriers that we currently have in accessing healthcare and how AI and automation could be used in tackling those challenges and barriers and some of the challenges there are in terms of implementing these solutions. And end with a conclusion, recommendations, and then some Q&A. So the keywords in that topic is AI, which is artificial intelligence, and then automation. Those are the keywords in the topic for this lecture. AI, artificial intelligence, basically means the stimulation of human intelligence in machines that are programmed to think and learn like humans. The keywords here are learn and think, and learning and learning things based on data. And automation is just basically using technology or software or machine to be rule based. You could now add AI to that, making that automation more intelligent and even requiring less from humans. So the key takeaway from these terms is that they are related, but they are not exactly the same. You could use AI to automate tasks, but you could automate tasks without necessarily currently have in Africa and in Ghana when it comes to access to healthcare. There are several factors. I just have narrowed them down to these four major blocks. We have geographic and transportation barriers. This is a common barrier affects a huge population in the global south, low middle income countries, where we have people living several kilometers to the nearest hospital. The routes and cost of transportation is very expensive. So we see people missing appointments because they are unable to afford transportation, or even the transportation is already a factor that impedes healthcare access. There are so many ways we could solve this, but in the next few lectures, few slides, I'll talk about how we could use AI and information to kind of tackle this particular barrier. But the obvious way of trying to solve this is obviously, building more routes, connecting more cities and more communities, and the government have tried to implement certain interventions in trying to do this. So, we have try to decentralize and democratize access by building more facilities, of course, transportation to kind of connect these communities to not just within healthcare but education and other social amenities as well. So there are so many ways that you can solve this barrier, but we'll see how AI could be used in a much more scalable and much more less resource intensive way to solve this. Then we have health workforce shortage. Uh, Globally, Africa has only about 3% of the global health workforce, and this is projected to reach about 6.1 million workforce shortage by 2030. And it means that at this rate, where the rate at which we are producing workforce, the health workforce, coupled with our recruitment rate and retention rate, we will not be able to meet the target that is necessary to achieve universal health coverage by 2030. And it's even projected that there's going to be that shortfall of 6.1 million by 2030. So this is one of the challenges that affect access to healthcare. We could solve this again by building more schools, increasing recruitment rates. We have that paradoxical phenomenon where we have workers sitting in a house and yet we need more workers. And so there's that paradox where we have a need for help, more help workers, and yet the recruitment rate does not correspond to that. And we have very low retention rate as well. People are employed and within a year or two, people already left and they go to a different part of the country or different part of the world. And so there's that where you have reduced intake, training capacities by the are limited. We have people who are qualified to go into school, medical school, nursing school, and yet they are unable to because the school have limited capacity to take these. We have newer private schools that are coming up to absorb these, and that's one of the ways of actually solving this. But we could also see how AI can solve this challenge with our carrying capacity. Then we have high disease burden, which Africa has about 25% of the global disease burden. And so that high disease burden with a limited workforce shortage, that is a recipe for poor access and also subsequently poor outcome of health. Then we have a poorly integrated health system where data sitting in one facility is not accessible to another facility, even within the same network. And so you have patients who have been seen in one hospital, goes to the next hospital and on a referral, and the next doctor cannot access the information about this patient. So it means that all the labs, all the investigations, and all the treatments and everything that was done for this patient in this facility is in a silo, and the whole process is started all over again in this new facility. This is not just only expensive, but it compromises the quality of care. You're supposed to have that continuum of care where one person hands over the baton to the next and it continues from there. You have to restart the whole process. It compromises the quality and it's expensive for the patients as well. So all of these are some of the factors that are some of the barriers to healthcare and in the patients. You have poor infrastructure in general. The health system itself is under financed, have limited health financing, and then you have very high, out of pocket financing, healthcare spending for patients. There are these several factors which all come together to affect access to healthcare and the quality and outcome in general. So I would now switch gears to see how we can leverage AI and automation. If I say automation here, I'll be talking about AI-based automation. So if I say AI, I'll be talking about it too. So we'll see how these two technologies could be leveraged in solving these barriers one after the other. So the geographic barriers. One of the thing is if the patient cannot come to you, then you go to them. So we have hospitals already have interventions where they have outreach programs and they go to various facilities. You have nurses and some physician assistants, doctors who go out to visit patients in their various communities for various interventions. Now, this is very resource intensive, and so if you have limited resource in your facility, you have limited health workforce in your facility, you will not be able to do this. And so it means that patients who are under your care or who are in your health system who are not able to come to your facility will not be able to achieve get access to that care. And so one of the ways we are able to do this is by using telemedicine. This is one of the topics that a lecture has been given on, where we'll talk about telemedicine in general and its role in access. Now, you have telemedicine, which you could just use you could use any communication platform to deliver telemedicine. We have various facilities that have dedicated telemedicine platform. But with a traditional telemedicine platform, what happens is that you have a provider who is sitting in your hospital or wherever the person is, and then you have a patient or a receiver who is at the other end. Typically, what it means is that you also need, the qualified person who is at the provider end. And so if you are just using your traditional telemedicine platform, that is what it will mean. You have to recruit people to join. Sorry, can you hear me? Sorry, can you hear me now? Hello, can you hear me? Hello, can you hear me? Yes, can you hear me?
Are you on?
Yes, I'm on. Can you hear me?
You can't hear.
I can hear you guys. I don't.
Yes, I don't know whether the way this
Which of my slides are you seeing now?
is the telemedicine argument.
Okay. Yes, that's where I am. Yeah, that's the slide I am on. Yeah, I can hear you. Yeah, I can hear you. Okay.
My internet is quite sensitive. I have a laptop with me, so I don't know. I'm asking him to maybe log in again. But we're not there. This is an active developer. You are not control the function. You are not available. What everything was for. Did you see you couldn't get the one there was so many. Go ahead and let Dr. Kuzi, can you log in again?
Okay. Can you hear me?
Have you moved the slide?
Dr. Kuzi, you can hear us, right?
I can hear you through the phone here.
Yeah, what we have to do is postpone. You know what? I can even go. Like this. Like that.
Okay. Apologies. We're still having some technical challenges in terms of we can hear him on WhatsApp and those on YouTube can hear him, but for some reason, connectivity here is not optimal. So what we will do is we would hold on to the rest of his presentation and try to find out a slot, maybe tomorrow, depending on how things are going to run. But we will let him send his slides as well, so we can be able to share the slides. I think that we will have another session on AI tomorrow, which is going to deal with the data issues. What Dr. Andre mentioned is a key issue, but we will see how we are dealing with it. There is data in Ghana, just that it's not organized in the form that is easily usable. So we shouldn't go out today to think that because we need data to train the models, the AI models, to be able to work well for us, the applications don't apply to us. No. There's a huge data that in Africa, in Ghana, that is being used across the world, and we have to do better in getting it organized. I'll wrap up with a couple of points from the presentations, and then I'll hand over to Dr. Edusei. I'm sure there might be some promotion before we close on. The first thing is that, yes, AI is going to be a challenge to the health sector as well. There are physicians who are worried across the world about how fast AI can do some of the things that we do in routine basis. But as we said, more jobs will be created by the use of AI. A lot of the surgeries that we do, which Dr. Aqua mentioned about, most of them are going through these processes. Currently, as we speak, we have an AI tool that is diagnosing TB better than what we used to. Radiologists are having to make sure that everybody incorporates AI into their readings because it can generate things faster and more accurate than what our traditional readings can do. These are facts about it. I also like us to have a take-home that in the private sector, if we want to also move forward and be at the cutting edge and attract the right team and to boost our practicing as is being spoken about, we should be thinking about how we can be able to incorporate, those of us who do a lot of telemedicine, we're using it already. So let's be thinking along this line. Let's be thinking along this line. On that note, presentations. Thank you very much for listening.
Hello. Hello.
Hello. Good afternoon. Good afternoon once again. And then thank you so much for the opportunity from NS Chemist Limited. We are so proud to associate ourselves with private medical practitioners. And for some years now, we've been going with you in all your AGMs. The one that was recently held in Accra, that is Sunny Lodge, you were there. And this year, by His grace, we are here again. We've passed some catalog around, and basically those catalog contains all our products that are manufactured locally in Ghana. And in the catalog, we have close to, I think Doug wants one of the catalog. In the catalog, we have close to 200 products that you may not be aware of, or maybe thinking that we have stopped manufacturing. That is the main reason we did this catalog, to serve as a guideline in taking decisions, especially in your facility. So at NS Chemist, quality is our hallmark. Can I have the pointer? Thank you. Quality is our hallmark, and NS Chemist is a household name. But then most don't know the history behind the company. So in 1986, it was established as a one-man business, and in 1993, as a limited company. We have a plant that was built to support the importation of our medicines, and it's located in Tema Heavy Industrial Area. Occupies about 2.3 acres of land. And let me also state that currently we are building a state-of-the-art facility, European Union standard GMP, that is almost at the stage of completion. And this new plant will serve as a IV parenterals, drops, as well as some ointment. So at NS Chemist, we ask, why do you pay for more when you can actually pay less for quality that you deserve? And in NS Chemist, we pride ourselves on quality. And clinicians here, senior ones, you may have been using our product for years, and I'm sure that complaints may have come, but it's on a minimal level. So we provide quality and affordable medication to the entire nation and even beyond. We have branches in Sierra Leone. We have branch in Nigeria. We have branch in Liberia. And we have other distributors across the West African countries. This tells that our product meets international standard. So we don't have substandard in our dictionary. We manufacture according to international standard. Because of that, we manufacture those days. Panadol was being done locally by NS Chemists until that was rolled off recently. And we are currently manufacturing for Exeter Pharmaceuticals some of their selected products locally here in Ghana. That is a UK-based pharmaceutical company. So some of the areas that the factory currently handles, we have the analgesics, like the Kefin, the Enafin. This is our Brufen. The Kefin is a combination of our cyclophenac and paracetamol combined. We have our anti-diabetics, that is our Enafage Glibenil. We have our anti-malaria like Malatu, and so on. We have antimicrobials, which I'll be talking about. I'll be going a little details on one of them. That's called Enafox tablet. And then we have our antitussives, that is our stop-off ranges. And then vitamins and minerals like Nescofa, Kidivite, and so on and so forth. So zooming down to our main discussion for today, we have a third-generation antibiotics, which has been in the market for some time now. So the generic name is Cefpodoxime, which is bactericidal agent that acts by inhibition of bacterial cell wall synthesis. And then also, basically, it's a third-generation cephalosporin, which you might have been using. The second, sometimes in your clinic, in your treatment. So the areas of coverage, we have the gram-positive and the gram-negative areas, like all the staph aureus. And then when it goes to the gram-negative, which is more tuned in, we have the E. coli and so on and so forth. So introducing this afternoon, we have our brand of Cefpodoxime called Enafox tablet and suspension. Enafox tablet, the tablet comes in 200 mg per tablet in the box of 10 tablet BD, as well as the Enafox suspension, which comes in 40 milligram per 5 ml in 100 ml bottle. So it's a third generation cephalosporin, like I stated earlier on, has broad spectrum of activities, shows powerful actions against gram-negative and gram-positive bacteria, but more tuning as you grow in the generation, it's more tuning to the negative side. So it comes, like I said earlier on, 200 milligram tablet and 40 milligram per 5 ml. So in areas, we have the upper and the lower RTI, like the pharyngitis, which I'll share some studies on. We have also on bronchitis, sinusitis, tonsillitis, and even on otitis media, which is a very sometimes stubborn to treat. We have studies that has actually confirmed this indication. Uncomplicated urinary tract infections, UTI as well, typhoid in cases, and that one we advise that you give it as 10 to 14 days as is stipulated in the standard treatment guideline. Then acute community-acquired pneumonia, both the hospital-acquired and the community. And then SSTI, that's the skin and soft tissue infection. This is very strong in those areas. So this is a clinical studies on otitis media to evaluate the clinical efficacy and safety of Cefpodoxime projectile in the treatment of children with acute otitis media. That was the objective. So if you look at the second sentence, it says increasing bacterial resistance has led to concern about the current options for empirical antibiotic treatment, and this has prompted a search for effective treatment. So a prospective multi-center study was conducted on 1,380 children aged between 1 to 13 years with AOM who were prescribed, that is otitis media, who were prescribed 5 to 10 days course of ceftazidime Prostatil, and patients were followed after 7 to 14 days from baseline treatment, that is after baseline visit. And if we move to the results, clinically, 82.5% of patients were cured, which is very high, 16.4% improved, and then there was a failure of a therapy of 1.1%. This could be as a result of some reactions. Some people were resistant to some of the ingredients that were used in the medicine. The overall cured or continued cured and improvement rate of all related signs and symptoms was 98.94%. So, in conclusion, this is just an abstract. In conclusion, ceftazidime Prostatil is an effective, safe, well-tolerated antimicrobial agent for treatment of acute otitis media in children. It can be considered as an excellent choice for the empirical treatment of bacteria. So these are the references, as very current references. And then there's also studies on pharyngitis as well. This one was efficacy of 5 days of ceftazidime Prostatil for the treatment of pharyngitis in adults. And this was a comparative studies with 10-day penicillin V and amoxicillin clavulanic acid. So this, to compare clinical and bacteriologic effect of 5-day course of ceftazidime with penicillin and amoxicillin clavulanic acid. So at the end of the day, it was the method was a multi-centered randomized trial that enrolled 580 adult patients as well. Then if we move to the results, at the end of the treatment, clinical response rate was satisfactory in 157 of 107 of the patient that was enrolled on the ceftazidime, which represent 92.34%. And also 147 of 166 of patients that were put on penicillin V. And 168 of 177, that is representing 94.94% on amoxicillin clavulanic acid. So let's move to the conclusion. A 5-day treatment of recurrent pharyngitis with ceftazidime, which is initiated as CPD, was as effective and better tolerated than a 10-day treatment with PNV or AMC, that is amoxicillin clavulanic, and the risk of recurrence was low. The key word here is the risk of recurrency. If we look at the result, some at the end of the day, after a follow-up, there were recurrency in some of the patients that were put on other products. These are some of the references, which is also one of the latest studies. So recommended dosage and pack size. It's recommended to be taken as BD, that is for as much as 14 days, depending on the indication you are using it for. But the minimum standard dosage is for 5 days BD, BD for 5 days, or BD for 7 days. That is the minimum recommended dosage. But like I stated earlier on, in some indications, especially in typhoid, it's recommended that between 10 to 14 days and as well. So we've come to know that at the end of IV ceftriaxone injection at the ward, clinicians get it difficult to even discharge the patient on third generation cephalosporin because of either the price or because it's not available. And clinicians sometimes even have to go to the second generation with the cephalosporin to give to the patient, or ceftazidime, which therapeutically this has more eradication than the ceftazidime. So with patients who are on IV ceftriaxone, we recommend that you discharge them on tablet ceftazidime with the brand name Enafox. So that is it about Enafox. The BD is a BD dosage for 5 to 7 days, and then also recommended to be used as oral after IV ceftriaxone with patients who are on admission. So this is just a quick reminder in the next 2 minutes. We have our next COFA. That is our iron 3 hydroxy polymaltose complex with added advantage of folic acid and B12. Basically, in pregnancy, especially our gynaes here, who pay particular attention to the elemental iron. The capsules contain 100 milligram of elemental iron of the capsules, and then also the syrup comes with 50 milligram elemental iron per 5 ml. So women during menstruation, growing children, athletes, as well as use it for normal routine. Our Mala2 contains artemether lumefantrine. It comes in 2120, also that is the 24, and then it comes in 4240, that is the 12. It also comes in 8480, that is the 6, the preferred options. And then also comes in the well-flavored suspension for pediatric use. Then our Gastrone, one of the unique formulation antacid in market that contains no sugar. Therefore, your patients who are diabetics, or who cares about the sugar content of a product can be recommended for this. It comes with dry aluminum hydroxide in an equivalent base, that is 250 milligram, as well as the magnesium in 250 milligram, to serve as a balance where there won't be any dysentery or where there won't be any constipation. And then it comes in high content of cymeticone, which acts as an antiflatulent, especially in a setting like this where you are not walking, where, you sit in one place for so long, at the end of the day, indigestion and stuff set in. So for stomach ulcer, indigestion, heartburn, flatulent, we recommend. Recently, we added one of the flavors to it, that is Gastrone Plus. That comes with added advantage of Zitacane, which most patients, or some patients, when they have this ulcer, this comes with this associated pain. So this is a local anesthesia that actually reduces the pain. That is Gastrone Plus, and also comes with sodium arginate, which acts as an antifoaming agent. So our stop cough ranges, which is well elaborated in a book with adult dose. We have adult children formula as well as the baby formula. We have the carbocysteine as well in 5 and 2% for adult and children. And then, very importantly, our honey cough. Honey cough is a honey-based cough measure that comes with one variant containing garlic, and then other variant it does not contain, because some people may react to garlic. So other natural herbs. This is a non-sedating, non-drowsy cough measure for your busy patient who don't have time to even sit at home to rest. This is the best option for them. That contains, like I said, natural garlic, natural honey to reduce the mucus and then expel it off. So advantage of honey cough is that it's non-sedating, non-drowsy. It's a natural remedy for all type of cough, and then also for throat irritation as well as sore throat. And then the last but not the least is our Kidivite. This also for pediatricians here, gynaes here, as well as GPs here, who sees a lot of children. This is ideal for your kids. Contain 12 vital vitamins for your growing children, especially now that they are back from school. To boost their immunity, think of Kidivite. And also to boost their appetite, Kidivite is the best for them. It comes in drops as well as in syrup of 200 ml. Thank you.
Precise Medical, be ready. Start getting ready. But let's get 1 or 2 questions for him. Precise. Okay, Precise, come.
So you have 7 minutes. Okay. It's even too much. Good afternoon. And thank you very much for this opportunity. I think we've sat down for quite too long, and I would try as much as possible not to take much of your time. Precise Medical Supplies has been around for about a decade and a half. We started in Takoradi, and we've extended our food to Accra and do some aspects of Kumasi. What we do is we are into medical laboratory, consumables and equipments. And we began by making sure that aside selling the normal laboratory equipments and consumables, we know quality in terms of the lab is very essential. So we went ahead to set up a lab in addition to our sales, such that anything we sell, we use and we validate. And I'm even so much happy that I have clients amongst you that can attest to the good work we're doing in that space. So for now, Precise within the last 15 years has set up 2 laboratories and then 2 sales points where we sell all medical laboratory equipments and its consumables to most of the private health facilities that we have around. We started with private. We never went to public. We started and we ensured that most of the standalone labs and the private health facilities would enjoy our product. So I know for Precise, as we speak, some have not seen it before, but we are growing in leaps and bounds. And this is an opportunity for us to partner together to do a good work. Okay, can you go to the next slide for me? Yeah. So as you can see, we specialize in supporting private clinics with reliable. Okay, thank you. Reliable and affordable and fast-moving medical products. All the RDTs we do. For dental, we only do the consumables like your cotton, the spirits, and all that. And for the laboratory equipments too, we do. These are some of the products we have. These are just a few that I listed. And then the same applies to these ones. Most of the things we have are our own brand. We've grown to the extent that we've matured into our own brands. So, and we rep for some of the reputable companies also around. Okay, so I would just want to run through. So if you see any product with this, it comes from Precise. The PD is Precise Diagnostics Biotest. And the advantage is that when you use our product, you can easily contact us for feedback and everything. We don't buy from the open market and just sell to you so that when you come back with a complaint, we'll say we are done with it, we only sold to you. No, that's not what we do. We ensure that you use to the end, give us feedback on how best we can improve. And by October, we'll be bringing in new PD products that are of combo-based because we want to reduce, one, the price, accessibility, and affordability. So in November, for those who will be going for the Private Health Facilities Association, we'll be demonstrating our combo products. So you'll find HIV, syphilis, Hep B, Hep C combined. And then for our G6PD, we now have a product that you can easily test within 25 minutes. You don't need to wait for the patient to wait for 3 hours. All are demonstrated or they are displayed outside. That can easily be shown to you. Fortunately, we brought most of the products here that you can see feely, as we always say. So this is our brand. We do the distribution. We do the training and everything, including the reagents. So if you see this anywhere, it is coming from Precise. This is just 2 weeks ago, we had training on all the equipment that we use. So these are our engineers going through the training. This is our semi-auto analyzer. That is also the same brand, Horon. And then this one, this is our baby, the kid on the block. If you see Jitin 110 hormone analyzer, I know some of you are using it. You don't know where it's coming from. The sales guys just come to sell. It is coming from us. We brought it into the country. One of the things we've noticed is that when people use for a while, we need to recalibrate it. Most of the sales guys cannot do. We do it free of charge in Precise. So if you are using this hormone analyzer, it does 26 tests all the hormones, HbA1c, PSA, the D-dimers, the CRPs, it does all. If you have any of these machines and you've not calibrated it before, please, let's meet and we'll do it for you free of charge. So this is our contact. I promised you I won't keep long. I won't even spend 10 minutes, and I've done it. Thank you very much. Let's meet after this place. We would want to partner with you because having the best results from your lab ensures that your clinic also retains a good reputation. I'm grateful for this opportunity. Thank you very much.
Yes. So, endoscopist, they've gone out. Please, any questions for Precise Medicals?
Yeah.
Stanley, you, just stand up.
How much is the hormone analyzer machine, please?
Okay. So with it comes with a starter pack and everything plus the installation, 50,000. So we are giving you the machine, the installation, and then the starter pack. The starter pack comes with the diluent, the lights, and then the cleaner for a start. 50,000 cedis.
Now, your reagents.
Yeah.
Do you get constant supplies, or sometimes you run out? In case you run out, do you have other companies that sell reagents that work on your equipment? And then secondly, do you have 5-part hematology analyzers?
Yes, we do. We do. We have 5 parts. For our reagents, for you, the buyer, you can choose whether we should open it or close it for you. But it's your choice. If we open it, it's compatible with the Mindray reagents also. So you can easily use them. So for those who use Horon, they use, and for those who use Mindray, most of them also buy even the probe cleansers from us. So it's open. So it's either ways. But once we are selling, we always know it's important for us to stock our reagents. So it's always in constant supply. And then you asked another one concerning the reagents. For all our chemistry reagents also, our brand name is Recon. So if you should see Recon, R-E-C-K-O-N, it's coming from Precise.
For the hormonal analyzer,
yeah.
When do you decide when to calibrate it?
Yeah, sometimes you need to check your results. I've had instances where I think somebody's result was way, as for the PSA. Apparently, he hadn't calibrated it for like 3 years since he bought it. So you know, it has a reference range that you need to look at. There's the client went to another place and noticed that the results it was giving.
I think you have to take a decision on this. Maybe you have to consult your suppliers, because like a car, you have a number of kilometers after running. You have to change engine oil, and you don't have to wait till the car starts getting problems before you intervene. You should have a standard that, or maybe after 2,000 tests, the machine has to be recalibrated. You don't have to wait till you start getting, because you are dealing with patients.
Yeah,
and you wait till you start getting wrong results. By then, the hammer has already been done.
Yeah.
When you start, you won't even know that you are getting wrong results. It takes time before you realize so.
Thanks
so
for
have a standard.
Thanks for the feedback. We noticed this ones when some people went to buy the equipment on the net and brought it into the country and did not even know how to get through with the servicing. Frankly, we use them, and frequently we get the updates when it is released. So I'm grateful that you've brought this up. Now we are gradually getting those who had the machine, although they didn't buy it from us. But once it is our product, we ensure that we enable them to have the best of care concerning the equipment. So I've taken it on board. I think it's something that we need to share. Thank you very, very much.
Thank you so much. And that's coming this year, if there's any questions for them. Otherwise, we thank you. But you have a question for?
Sorry, I have one more question. Maybe this is a general one. There are several companies that bring in equipment, analyzers onto the market. And you realize that they keep having different ranges as their normal ranges. So you find out that someone's normal HB range is 12 to 16. So somebody's HB is 16.5, the machine reads high. Platelets, the same thing. What's being done about all this? Because you are one of those who bring in equipment, I think there should be, you know that there are standardized ranges.
Exactly.
So how comes the machines are given different ranges? Is it because they are made by people of a different race, so they are focusing on their race, and we are not producing any equipment here, so we can't get?
Yeah, thank you. Indeed, what you're saying is true. There should be standardization. Standards Board often does that on behalf of. They don't even do it for the suppliers. They go straight to the facilities to do the calibrations. But most often, although there are differences in terms of the ranges, it shouldn't be that much. 0.2, 0.1. If it goes beyond 0.5, there's something wrong, frankly speaking. So, you know, one of the things I worry about is that in our part of the world, for the few experiences I've noticed, most often we look at the price. So if I come and I say my hematology analyzer is 40,000, people would jump without necessarily considering its usage. Has somebody used it before? What are the readings? Fortunately for us, anything we sell, we use. So I can easily give you a plethora of the results we've generated from the machine for you to take a decision as to whether it's a good equipment or it's a bad equipment.
Thank you so much.
Thank you, sir.
Yeah. A word of advice from Utumfo.
Thank you very much. Precise, thank you very much for the presentation. I'm very excited to hear that at least efforts are being made to make distance here in Ghana. From what Dr. Mensah, last but one speaker, just said, I just asked my colleague whether Standard Board has been at Kintampo before. He is in Kintampo for more than 20 years. And his response was no. I am in Kaswak.
But they've been there.
No.
Then you are.
So what I'm trying to say is that I think you and your cohorts should try to find a way of introducing what Dr. Mensah suggested. When they buy the machines from you, have it a point that after 1 year or 20 uses or 50 uses, we have to come and do the calibration. Don't expect Standard Board to do it for you or the facilities to go and take it to Kolebu. Some of us, we take our machines to Kolebu for recalibration and all those sort of things. And I think sometimes maybe it's not very pleasant.
Yeah, thanks for the advice. Maybe I need to also add that we know the machines are also upgraded. So for that, we do them frequently. They are also upgraded. We do that frequently. I even have the softwares in my car now. So we do that frequently.
That calls for further questions.
Thank you very much. I have one question for you and one general information. Now, the first is the general information. There's a lab in Accra called 0.2. But they have done a lot of calibration or a lot of research, and they have fixed theirs for 6 point something. I think it would be better for all of us to get in touch with our administrators to be able to get in touch with such laboratories that have African or Ghanaian records so that we can use them as standardized records in our facilities. This becomes very important because I think some of us know, or some of you know, that the standard SpO2 machines that we use are not very effective for black people. I don't know whether anybody has read about it before, but the values we get from Caucasians is different from the values we get from Africans. So these are some of the things that we have to know and keep in touch. Now, is NS Commissioner? NS Commissioner, I have a problem. The problem I have is you have a product on the market which is an equivalent of cocodamol. The standard cocodamol is 8 milligrams to 500 milligrams. 8 milligrams of codeine and then 500 milligrams of paracetamol. But yours is 30/500. That is 30 milligrams of codeine and 500 milligrams of paracetamol. Now, when you write a prescription of cocodamol and you even put the specific dose there, like 8/500, when they go to most of the pharmacy shops, you know, the pharmacy is not always there. Very few pharmacies sit in the pharmacy shops. They use a license to open the shop, and they are never there. So, if you even specifically write 8/500, they will give them the 30/500. And I've seen a lot of people complaining about cocodamol from NS Chemist. I asked for a few samples and I realized that they were all 30/500. So please, I think you better do something about that. Either you bring it down to the standard 8/500 or tell the pharmacy shops that they have to be very careful about what they give out to people. Especially they should look at the doctor's prescription and make sure that they do the right thing. And most of the times, if it's a private sector, the doctor's telephone number is somewhere on the prescription. So if they are in doubt, they should always call. It's very important. You see, I see old people only. And when they take the big doses, they go to sleep and they don't wake up. It's very, very important. Thank you very much.
Thank you.
Yeah, thank you very much. So we've had a very long day, and we are about closing. Just 2 announcements. Members will meet at the AstroTurf at 5 p.m. for a cocktail. And from here, is outside there. From here, okay. And at 7 p.m., there will be a council meeting. Now, with a round of applause, let's invite, council meeting will be here, 7 p.m. Let's invite the president of SPMDP to give his closing remarks. You've done a good job.
I don't know why Secretary is saying round of applause. It's one of the most hardworking secretaries I've come across. For instance, this is a secretary where you get minutes, full minutes within 24 hours, and there's 0 corrections since he became secretary for 2 years. So a round of applause for him. We've never corrected his minutes before. He puts it out on time. So we've come to the end of the first day. My senior colleagues and colleagues, you have been very cooperative, very engaging. The first day has been successful. So tomorrow is our opening ceremony, and then it continues with a scientific session in the afternoon. Yeah, I think other announcements or tomorrow more people are going to join us. We have our keynote speaker, we will have, because of this tragedy that has occurred, we're not very sure if our guests, special guests, will be with us, but hopefully they may join us. And then we'll have our usual opening ceremony tomorrow. So on this note, I want to congratulate all of us for bringing the first day successfully to an end. And then we pray that tomorrow also goes in. Thank you very much.
The dressing for tomorrow for members will be the Spmdp group. Have to borrow one. So you go to the AstroTurf for. Oh, but I don't have a pot value, so you can't use mine. You go to the AstroTurf for our cocktail. Thank you very much.